Okay, we're going to go ahead and get started. Good morning. Thank you everyone so much for joining us for the IBD Pharmacist Virtual Symposium. We're so excited to have such an impressive agenda today with speakers from all over the nation who will be speaking on different topics of expertise. Today's program is CE accredited. Here are the educational objectives. By the end of the program, you should be able to discuss knowledge on the current treatment guidelines, emerging therapies, and integration of biosimilars in Crohn's, aiming to optimize patient care and outcomes, enhance skills in management of non-IBD related symptoms, counseling patients on new ulcerative colitis therapies, and apply strategic shared decision-making practices to improve treatment adherence and patient satisfaction, as well as explore and identify care strategies from peer-presented projects focusing on practical application to advance patient management in inflammatory bowel disease. I would like to give a huge thank you and shout out to our amazing planning committee, Michelle Becker, Shuba Bhatt, Shannon Kampa, and David Choi. They will be moderating the Q&A of today's session. And without further ado, I will turn it over to our first speaker, Marina Ivanov from Mayo Clinic, Arizona.
Good morning, everyone, and thank you for joining today's event. I am Marina Ivanov, and I'm the Inflammatory Bowel Disease Clinical Pharmacy Specialist at Mayo Clinic, Arizona. Today, I'm going to start off the presentations by reviewing the advancements in the management of Crohn's disease. Here are my disclosures, and here are the learning objectives of today's presentation. I'll review by starting the Ustekinumab biosimilar agents on the U.S. market, review the clinical data on the new interleukin inhibitors used for Crohn's disease, and the head-to-head data that we have with Ustekinumab, in addition to data on switching from one interleukin inhibitor to another. Okay, here are my disclosures, and here are the learning objectives. I will provide an update on the Ustekinumab biosimilar agents available on the U.S. market, review the clinical data that we have on the new interleukin inhibitors used for Crohn's disease, and the head-to-head clinical trial data that we have for Ustekinumab and data between switching of the agent, describe new data on the management of fibrostenosing small bowel Crohn's disease and the recent consensus statement, and also review the utility of Upadacitinib in treating penetrating fistulizing Crohn's disease. So with that, I want to present you with a timeline which illustrates all of the treatment options that we have for patients with Crohn's disease, starting with Infliximab in 1998 to the most recently approved Guselkumab in 2025, and really highlight that in the last 4 years, we've actually doubled in the number of agents we have available for our patients, which is great because we can offer more options, but also it makes treatment selection more complex. So for Crohn's disease, depending on severity of the disease, we have conventional therapy for mild to moderate disease. And then for more moderate to severe disease, we have biologics and small molecules with the recent addition of Upadacitinib. In this table, we have a summary of the Ustekinumab biosimilar agents approved for Crohn's disease. Starting January of 2025, we now have biosimilars available for Ustekinumab. There's a total of 6 agents available on the U.S. market. All of them are FDA approved for Crohn's disease. And to the right, I've summarized the dosing and how they're supplied on the U.S. market. And I want to highlight that the 6 milligram per kilogram dose, which is for patients less than 40 kilograms, usually used for pediatric population, it is not FDA approved. So now I'm going to begin with reviewing the Risankizumab data, starting with the Advance and Motivate trials. Those were the induction phase trials, and patients with moderate to severely active Crohn's disease who had previous inadequate response to conventional or biologic therapy were included. They received 600 milligrams IV, 1,200 milligrams IV of Risankizumab, or placebo every 4 weeks for a total of 12 weeks. Here's the data from the 12-week induction trials. We have the Advance and the Motivate trial data here to the left. The study outcomes looked at endoscopic response, clinical remission based on stool frequency and abdominal pain, and clinical remission based on CDAI scores. To the right, we have the graph here that actually summarizes the patients who were previously on Ustekinumab and received Risankizumab. Those are patients who did not respond to Ustekinumab in the past. And this data really helps us answer the question, if a patient was previously on an IL inhibitor, do they still have a chance of responding to another IL inhibitor? And the answer is yes. Based on the induction data that we have compared to placebo, patients who were treated with Risankizumab after failing Ustekinumab, they still met the endpoints of the study. Now, when patients responded to the Advance and Motivate trials, they were included in the Fortify trial. This was the maintenance phase. It was 52 weeks of maintenance, and patients were re-randomized and received Risankizumab 360 milligrams sub-Q, 180 milligrams sub-Q every 8 weeks for a total of 52 weeks. To the left, you see the data. Now we have deep remission that was also included as the result outcomes for the responders. I do want to point out here that compared to patients who are bio-exposed versus bio-naive, we only saw a very slight difference in response rates, which is great because we see that even if patients were previously exposed to biologic therapy, they still have a very good chance of responding to IL inhibitors such as Risankizumab. To the right, we have the data for patients who were previously on Ustekinumab. And the darker orange is the 360 milligrams. The lighter orange is the 180 milligrams. Again, we see that compared to placebo, both doses achieved the study outcomes. And there was a slightly higher numerical trend in the number of responders in the patients who received 360 milligram dose. With that, we may want to go with 360 milligrams for our patients who previously exposed to Ustekinumab. However, both doses, 180 and 360, are currently FDA approved. Now I'm going to spend some time reviewing the open label extension study for Risankizumab. And this is a great clinical tool that you can use in your practice when you're requesting off-label use of Risankizumab reinduction or extended induction. So these patients did not respond and were not in remission after getting 3 IV doses of Risankizumab. So what the researchers did is they gave them 3 additional IV doses of 600 milligrams IV, and they observed them at 26 weeks and then at 52 weeks. So what they saw, looking at the left, is that compared to 12 weeks, the clinical remission at 24 weeks was significantly higher. We had 53% of patients in clinical remission, 71% of patients at clinical remission at week 52. So with that, the conclusion of this extension study was that extended induction of Risankizumab was an effective strategy in increasing clinical response and remission rate. This may also suggest some delayed response to therapy in patients on Risankizumab as well. But again, this can be very helpful where you're trying to justify using additional IV doses or when you're deciding between continuing therapy versus changing therapy. This is the Crohn study I would like to introduce you to from the ANITA database. This is the largest cohort database of real-world data. It comes from Europe. So the goal for the study was to assess real-world effectiveness of Risankizumab in patients with Crohn's disease. This is a recent publication, and why I really find this valuable is because it closely relates to the patient population we see in practice. So patients had median disease duration of 14 years. Almost 1/3 of them were smokers. Almost 1/3 of them had perianal disease. Only 3% of patients out of the 857 patients were biologic naive. Almost half of those patients, 47%, had 3 or more previous failures. The primary endpoints here were steroid-free clinical remission after induction with Risankizumab and long-term at the end of follow-up, and the influence of previous use of Ustekinumab and number of previous advanced therapies in short and long-term efficacy. So what they found is that after giving Risankizumab to this patient population, which was very treatment refractory, 56% of patients achieved steroid-free clinical remission after induction. About 61% maintained that after the follow-up. Remission was more frequent in Ustekinumab naive patients with short and long-term remission rates, and the higher number of prior advanced therapies was associated with lower remission rates. Here, the graph summarized the data between patients previously treated with Ustekinumab versus Ustekinumab naive. There was a statistically significant difference in the steroid-free clinical remission and the long-term remission rates between the population. However, I do want to highlight that although we see those results, Risankizumab is still an effective treatment option for patients who were previously on Ustekinumab. This is the sequence trial, which is a great tool for your clinical toolbox, and it allows us to actually rank the interleukin therapies that we now have. This was a head-to-head trial and compared risankizumab to ustekinumab for moderate to severe Crohn's disease. What I want to highlight here is that the study population was TNF refractory. So those are biologic experienced patients. And after looking at the clinical remission, endoscopic remission between the two groups, it was concluded that risankizumab is actually superior to ustekinumab in achieving clinical and endoscopic outcomes. A little bit on risankizumab for pediatric patients with Crohn's disease. This is not currently FDA approved. We don't have any published clinical trials right now. There's an ongoing clinical trial. There are some case reports that we have available where they use standard Crohn's disease dosing in those patients. For therapeutic drug monitoring, we also have risankizumab drug level available, which was recently added. So this is available from Mayo Clinic Laboratories. The cutoff value is thought to be around 8.1. And I do want to point out that data is limited on the actual relationship between the drug trough level and the drug response compared to some of the other options that we have. This can be considered as part of the reactive therapeutic drug monitoring for patients who you're trying to decide between optimization versus changing therapy versus continuing therapy. It can also be helpful with insurance appeals where you're requesting off-label or escalated dosing. And I do want to highlight that it's not always covered by insurance and it can be expensive. So choose very wisely who you're going to recommend this for. Now that I've summarized the data for risankizumab, I'm going to move to Mirikizumab, brand name Onvo, and introduce you to the VIVID trial. The VIVID trial looked at the efficacy and safety of Mirikizumab in patients with moderately severely active Crohn's disease. This trial was a randomized controlled trial. It had a total of 3 arms. The first arm received Mirikizumab 900 milligrams IV every 4 weeks for 3 doses. Then they continued with maintenance of 300 milligrams sub-Q every 4 weeks. The second arm received ustekinumab 6 milligrams per kilogram for induction, and then 90 milligrams sub-Q every 8 weeks for maintenance. And the third arm was the placebo. They got IV every 4-week placebo for 3 doses. If they were responders, they continued with placebo. If they were not responders, they were changed to Mirikizumab induction, followed by maintenance. Here are the results from the VIVID trial summarizing the primary endpoints. Starting from the left, we do see the data in all participants. The blue was placebo, the red or orange was Mirikizumab group, and the green was the ustekinumab group. So this is a trial that allows us to also have an active comparator. So looking at all the participants, we do see that compared to placebo, both Mirikizumab and ustekinumab achieved the primary endpoints of clinical remission and endoscopic response. Now, shifting our attention to the right, where they have divided the patients between those who were previously biologic exposed versus those who are biologic naive, I do want to highlight that we see a very good response rates and very similar response rates in the Mirikizumab group, which again makes Mirikizumab a great option for patients who are biologic experienced as well as biologic naive. Now, combining the data and looking at it as a whole, we did notice that Mirikizumab compared to ustekinumab, Mirikizumab is considered non-inferior to ustekinumab in achieving clinical remission. Again, this is another head-to-head data that we have, which helps us rank the therapies between the interleukin inhibitors. However, I do want to point out that looking at the patients who were previously on biologic therapy, there was a slightly higher numerical difference in the patients who were previously on Mirikizumab versus those on ustekinumab. A little bit on Mirikizumab for pediatric patients. In the VIVID trial, there's actually a total of 6 adolescent patients who were included. We do not have data on efficacy. We do have data on safety. There's an ongoing pediatric Crohn's disease trial called Macaroni, and another one which is called Shine On. So more to come on that. Now I'm going to start with reviewing the Galaxy trial. This is the newest interleukin inhibitor that we have, Guselkumab or Tremfya. The Galaxy 2 and 3 trials review the efficacy and safety of 48 weeks of Guselkumab for patients with Crohn's disease. So this was a randomized control trial with 4 arms. Again, we do also have an active comparator here. The first 2 arms received 200 milligrams IV every 4 weeks for 3 doses for induction. The first arm continued with Guselkumab 200 milligrams every 4 weeks for maintenance, which is the higher maintenance dose. The second arm continued with the lower Guselkumab dose, which was the 100 milligrams every 8 weeks. The third arm received Ustekinumab 6 milligram per kilogram for 1 dose, followed by standard maintenance. The fourth arm received placebo IV every 4 weeks for 3 doses. If they were responders after induction, they continue with placebo for maintenance. If they were not responders, here they changed them to Ustekinumab induction, followed by Ustekinumab maintenance. Here are the results after induction compared to placebo. The green is patients treated with Guselkumab 200 milligrams IV. The gray is the placebo group. Compared to placebo, we do see higher clinical remission endoscopic response rates in patients on Guselkumab, which is why it's currently FDA approved for Crohn's disease. And now here, looking at the composite co-primary endpoints. Now here, the darker green is patients who got the higher maintenance of 200 milligrams sub-Q every 4 weeks. The lighter green is patients who got the lower maintenance, and the gray is the placebo. Compared to placebo, we see that both maintenance doses had achieved the composite co-primary endpoints of the trial, and there is not much difference between the 100 milligram and the 200 milligram maintenance doses. And that is why we have both of those currently approved. Now here, and this is a busy graph, but what they did is they also added the purple, and the purple is the patients who were treated with Ustekinumab. And this allows us to draw many conclusions, including a head-to-head comparison between Guselkumab and Ustekinumab. So looking at the data, what we see is that Guselkumab is superior to Ustekinumab in achieving clinical remission and endoscopic response. Now, clinical remission rates in patients with Guselkumab was around 70%, a little bit lower with the 100 milligrams sub-Q every 8 weeks versus the 200 milligrams sub-Q every 4 weeks. Now, this is the phase 2 Galaxy extension study for Guselkumab. Patients who were in the initial trials were given Ustekinumab and did not respond were changed to Guselkumab maintenance of 200 milligrams sub-Q every 4 weeks without being given an induction. There's a total of 17 patients with inadequate response. So they observed those patients, and what they found is that the majority of patients who did not respond to Ustekinumab but received Guselkumab achieved clinical remission 16 weeks after the switch. Also, majority of the patients had endoscopic response 1 year after the switch. And again, this helps us answer the question, if you have a patient who did not respond to Ustekinumab, Guselkumab is a potential treatment option where patients can achieve higher clinical remission and endoscopic response rates. This is the Gravity phase 3 trial. This is a different trial, which reviewed Guselkumab sub-Q induction, which is also very new and was recently approved. So this was a 3-arm trial. It was a randomized control trial where the first 2 groups received Guselkumab 400 milligrams sub-Q every 4 weeks for 3 doses. And after that, they were changed to 200 milligrams sub-Q every 4 weeks. The second arm received 100 milligrams sub-Q every 8 weeks, which is the lower maintenance. The third arm was the placebo arm. Here, patients who did not respond to placebo were changed to Guselkumab 400 milligrams sub-Q every 4 weeks, and then changed to the lower maintenance of 100 milligrams every 8 weeks. This is a busy graph, but looking at the co-primary endpoints of clinical remission and endoscopic response, we do see that compared to placebo, Guselkumab 400 milligrams sub-Q every 4 weeks achieved all the co-primary endpoints, and that is why we now have Guselkumab sub-Q induction available in the US market. And with that I've summarized the data that we have in the most recent articles for patients and the interleukin inhibitors. I did want to go over the AGA clinical practice guidelines for the management of moderate to severe luminal and perianal fistulizing Crohn's disease. I do want to highlight for patients here who are biologic naive, the guidelines still list infliximab and adalimumab as one of the first-line therapies. There was also a recent meta-analysis which looked at all of the data that we have and suggested that TNF inhibition may be the preferred initial option for bio-naive patients when it comes to achieving remission and response. However, the second medication they recommend is ustekinumab, which is also recommended if patients have not responded to TNF inhibitors. What I wanted to highlight is that now that we have all that new data that we reviewed, we may be seeing some difference in changes to these guidelines during the next edition. Here, I've summarized the head-to-head clinical trials that we have available for ustekinumab in patients with Crohn's disease. There's a total of 5 trials that we have. The trials in red are the ones that I reviewed, which show that there is superiority over ustekinumab. Again, this helps us rank the therapies that we currently have when we're discussing different options with our patient. This is a summary of the interleukin inhibitor dosing. It can get very confusing now that we have 4 available agents on the market. So I wanted to summarize this for induction and for maintenance, what doses we use and when we start those doses. And now I'm going to transition to the most recent global consensus on the management of fibrostenosing small bowel Crohn's disease in clinical practice. This looks like a very busy table, so I'll try to simplify it the best way I can. So basically what this shows is that the researchers categorize different options based on being appropriate, uncertain, or inappropriate. So for patients who are biologic naive and are not symptomatic, the recommendations, what's considered appropriate is an anti-TNF agent with an immune modulator, or ustekinumab. Corticosteroids are only appropriate if a patient is symptomatic. If they're not symptomatic, corticosteroids are not an appropriate option. For patients who were previously exposed to TNF inhibitors, then one of the options is ustekinumab. Vedolizumab here is considered not appropriate. So that's really what the current guidelines say. We don't have anything on the other interleukin inhibitors, but potentially they may be benefit with using them as well. This is the Upadacitinib post-hoc analysis of phase 3 induction and maintenance trials. This is Upadacitinib used for fistulizing Crohn's disease. Fistulizing Crohn's disease is one of the toughest phenotypes to treat, especially for patients who failed first-line therapy with TNF inhibitors and are disease refractory. So here we have data for week 12 and week 52. Initially, patients received Upadacitinib 45 milligrams once a day for 12 weeks. And what we see that here is compared to placebo, there was a higher rate of external closure fistula opening and external closure perianal fistula openings and complete resolution of draining at week 12. So looking at the results, we definitely see a response in Upadacitinib. At week 52, patients received 15 milligrams or 30 milligrams once a day for maintenance. Again, compared to placebo, all of the outcomes that were reviewed were higher in the Upadacitinib group, which allows us to have another treatment option for our patients with the goal to improve their quality of life and minimize the risk for complications. Upadacitinib is not currently FDA approved for pediatric patients with Crohn's disease. We don't have any published clinical trials. There is an ongoing pediatric clinical trial called UEmpower. I did want to include 2 other studies that we have where Upadacitinib was used in disease refractory biologic competent patients. So the first one was a multi-center retrospective study which had 100 patients. The patients' age ranged between 9 to 18 years of age. Here, patients who were less than 30 kilograms received 30 milligrams for induction. Everyone over 30 kilograms received 45 milligrams for induction. At the end of the induction period, they did notice a clinical response was at 75%. Clinical remission was at 56%. The most frequent side effect here in patients was acne. In the other single center retrospective cohort that we have, again, those are disease and medication refractory patients to currently approved agents. They received Upadacitinib. There was about 90% response with induction, 65% steroid-free remission at week 24. And there was also no new safety signals that were identified. And with that, I wanted to wrap up my presentation and thank you very much for your attention.
Good morning, everyone. So I just want to friendly remind you to please utilize the Q&A chat box on the bottom of your screen. If you do have any follow-up questions, we'll have about a few minutes for the Q&A session. So happy to answer any questions in real time. So with that, Marina, I do have a few follow-up questions for you that have come through, and I think there's a lot of interest with the positioning of the IL-23. We're very fortunate enough to now have more treatment advances, thankfully, and more options to offer our patients. So if you don't mind, I would love your input on how do you differentiate between the IL-23 when you have a patient in front of you in the clinic? Which agent are you picking for a patient with Crohn's disease? And then if you could also comment, how do you think that with the introduction of the Ustekinumab biosimilars, how do you think that's also going to potentially influence the positioning of the IL-23s as well?
That's a great question, and it's something really we deal with in clinic all the time. I think what is something that I want to highlight is the most important thing about your patient is to be able to get them started on therapy. It's great that we have many different treatment options. However, it's also important to highlight that there's a very high financial toxicity associated with a lot of these agents. So the best therapy for patients are the ones we can actually start right away. So if I had to choose and I did not have any financial barriers, we can use our sequence trials and Galaxy trial data for patients, especially someone who is disease refractory and biologic refractory, potentially recommending something like Risankizumab or the Guselkumab. However, we still want to highlight that Ustekinumab and Ustekinumab biosimilars are still a very effective option for patients with Crohn's disease. So again, if we have to choose, we use those trial data and the head-to-head trial comparison to justify why we pick one over the other. But again, all those options are available and should be considered if a patient needs therapy.
Wonderful. Marina, can you also comment on some of the particular nuances that relate to the dosing? So for example, like the infusion time among the agent, the number of injections, the type of device, so some of the additional considerations that are unique to these types of medicine?
Absolutely. So it's great that we have more options. I think with the Risankizumab OBI, we've had a lot more patients be very comfortable with the injections because the device looks so much different. So for patients who have needle phobia and really uncomfortable, we have older patients who really enjoy using the device. I think that's a great option for them. Most of the devices, they do have like an on-body injector, which can be very easy. And we do provide teaching in the clinic as well for all of our patients. So again, with that, we do have that discussion because I want my patients to be comfortable when they use the medications. All of them were approved for at-home use. So with that, we want to make sure they're okay with giving it to themselves, and we go over the different administration methods that are available.
Perfect. So just highlight again, in addition to having more treatment options, we actually have more options within the individual medications that we can offer to our patients, which is excellent. So Marina, we do have one question that came through the chat. So do you have any experience or any literature that you've seen on using a repeat induction with Upadacitinib 45 milligram or doing like an extended induction in patients that have really difficult to treat fistulizing Crohn's disease?
For fistulizing Crohn's disease, I'm not aware if we have that data. We do have extended induction data with Upadacitinib in Crohn's disease as well, where patients can continue for a little bit longer. We also have some trials, or I would say it's more of reports that we have for higher dosing of Upadacitinib in patients with Crohn's disease when we have partial response. But in fistulizing Crohn's disease, I'm not aware of.
Wonderful. And we got another question coming through on the management of interleukin 23/12 agent that have patients that are pregnant or wanting to become pregnant. What are some considerations to note as it relates to that drug class and that patient population?
Great question. There's a recent publication on that actually that looked at that. Bottom line is we don't have a lot of data on the newer agents such as the Tremfya and Mirikizumab. So, however, we would not hold therapy for patients who are pregnant. We do review risks versus benefits. And the data that we actually have from the IL inhibitors is showing that it's safe during pregnancy and after pregnancy. So with that, we would not consider using a different agents based on that when we select therapy. Because again, the most important thing when you're treating a patient with Crohn's disease who's pregnant is to get good disease control, because that is what drives outcomes in the long run.
Yeah, so I just want to reiterate that, Marina, if you don't mind. So, really important to make sure that mom is healthy and stays healthy during the course of pregnancy and even pre-conception. So we know
Right.
that translates the best outcome for the baby.
Right.
Perfect.
And the data really hasn't shown any concerns with any of the IL inhibitors, really. They have very similar mechanisms of action. So with that, usually that is not a factor that plays a role when we decide between the therapies.
Wonderful. Okay. Marina, so we're going to be switching over and focusing on infusion site reactions and injection site reaction. Do you have any clinical parallels for patients that are reporting either an infusion-related or an injection site reaction? In this context, the participant did particularly ask about Risankizumab, so I don't know if you want to share what your clinical experience has been and what are some tips and tricks maybe to help minimize these types of reactions if they were to occur.
That is actually a great question. However, it's multi-component question because there's very different types of reactions. So, we have more sudden reactions, then we have delayed reactions. When it comes to infusions, it really has to do with what is their reaction. Are the patient having hives, rashes, itching, or are they having, different type of reactions that they're seeing, more of an allergy versus an infusion reaction. So at our center, we do pre-medicate patients we use Claritin and Tylenol. I don't think that's ever been studied to see if it does help with improving reaction rates. The actual reaction rates of Risankizumab are very low. But you have to individually look at the patient and assess what exactly is happening and are you comfortable with them continuing with this therapy or not based on the symptoms that they're reporting. Again, when we have had patients who had more reactions with infusions, but when they switch to injections, because we also have a different method of administration. For example, IV is 100% bioavailable versus subQ takes some time for that and the dose is lower. We have seen those side effects minimize and patients actually do very well in the long run. So you have to really assess the picture and see what exactly is going on to really decide how to proceed and if you're going to change or continue.
Perfect. Hi, Marina. So I appreciate all your time and input and an excellent presentation today. If you don't mind, if you're able to see the Q&A box, there are some additional questions that are coming through if you'd like to take the time to answer those if you're available. Otherwise, just a friendly reminder again that please utilize the Q&A box as the presenters are going through their presentation. We have some time allotted to ask these questions and get them real information in real time. So with that, thank you again, Marina. Appreciate your time and presentation today. And
Absolutely.
at this point, I would like to now hand it over to Alyssa Stewart. Take it away. The floor is yours.
All right. Let's see. Everyone see slides okay?
Yeah, Alyssa, you're good. We can hear and see your slides.
Perfect. Thanks. I'm Alyssa Stewart. I'm the GI hepatology clinical pharmacist at Atrium Wake Forest in Winston-Salem, North Carolina. Happy to have the opportunity to speak to you all about some of the successes that we've had in our institution with navigating the IV to sub-Q landscape. Just a very quick background. I know we're all versed in this, but several therapies on the market that either have to follow IV to sub-Q dosing or have the option to. As we're familiar with, IV induction dose or the series is traditionally authorized under medical benefits, and the subcutaneous self-administered maintenance dosing is traditionally authorized under the pharmacy benefit, and this typically leads to completion of 2 separate benefits investigations and prior auths. We are also very familiar with many of the challenges presented by IV to sub-Q dosing, particularly that many patients' medical and pharmacy benefits just don't talk to each other well or just don't talk at all. Maybe operating on 2 different formularies completely. So we run into situations where, IV is covered, but not sub-Q, and then vice versa. There's also difference in benefit structures between the medical benefit and prescription benefit. A classic example would be patients that have a supplement to help with their Medicare costs on infusions, but that does not apply to the Part D on the prescription side. We also know that exposure to and discontinuation of a biologic in these patients with very active immune systems raises concern for potential immunogenicity. And while that's much less common now with some of these newer therapies, it can jeopardize the ability for us to utilize that therapy in the future. And then across our institutions, of course, there's so many varied structures of how teams and groups are set up that have involvement and access for these medications. Different teams may work medical authorizations versus pharmacy authorizations. You've got your infusion suite setting and then your pharmacy setting that's dispensing. So lots of moving parts to communicate across. And, of course, this presents great pharmacy education opportunities too in this transition. We have a few different aspects of our process here at Wake Forest that we've found to be successful. This is just a quick roadmap of what we'll review. We do proactive IV and sub-Q benefit investigations up front before initiation and have sort of a pharmacist quarterback that oversees the outcome of both of those things and has a bird's eye view. We have MSOT, which stands for multi-step order transmittal, which is a tool in our electronic health record that can help us control the timing aspect of when that maintenance prescription is released. And then we also have a pharmacist-driven counseling time point as well. So diving a little deeper into that proactive IV and sub-Q benefit investigation. So at our health system, just kind of as a history here, there was an increase in pharmacist involvement in the IBD space in 2018 that led to a change in process for obtaining authorizations. And at the time, we were focused on Ustekinumab. So previously, the team was obtaining prior authorization for the IV induction dose, and then the prior auth for the maintenance syringe was completed just at some point after induction. There really wasn't much structure or organization to that. Kind of leaves us scrambling in certain situations. But then the process, after some pharmacy involvement, transitioned to pursuing both modalities upfront, those benefits investigation. And we actually compared access outcomes pre and post implementation of that combined process. So looking at insured IBD patients' ability to transition onto Ustekinumab maintenance after receiving that IV induction, there were actually 3 patients in the pre-period who never continued to maintenance therapy at all, and they actually abandoned therapy completely after IV induction. And then kind of in our post-process period, all patients were able to actually transition to sub-Q maintenance, but 2 were a little late in doing so. And so we'll kind of zoom in and characterize the reasons why patients did not continue on to maintenance in a timely manner. In the pre-period, 3 patients didn't transition at all to the sub-Q maintenance. A few reasons listed here: non-formulary status, denied appeal, unexpected high out-of-pocket cost on Medicare. You could argue that, I think there's other steps that you could take in these instances to kind of mitigate that, but this was also before kind of heavy pharmacy involvement. And then in the post period, again, all those patients transitioned to sub-Q, but the 2 with a delay were due to loss of prescription insurance, which is unexpected. Can't really control that. And then one whose plan actually required documentation of clinical response after induction, which, as you know, in that interval is a little bit difficult to establish sometimes. So that was delayed. I think a great benefit of this is the reduction in outright therapy abandonment that we were able to achieve after IV induction and reducing that fracturing in care. I think a huge benefit is it allows us to see upfront what we're dealing with, what we're up against, and it gives us a better overall picture of what we need to do, address proactively any access interventions that need to be addressed. And it doesn't mean that you necessarily have to have all of that buttoned up and ready to go before you proceed, but I think it gives you a good insight into what's needed. So a good example of that is back to the Medicare patient that might have like a supplement for that helps with their IV doses, but we may be looking at applying to assistance for the sub-Q. You can chat, eligibility with that patient, action items, things like that, get the ball rolling, but, we may go ahead and potentially infuse while we're kind of wrapping up that assistance piece. So really just kind of the ability to predict some of these things. I think too, this also has particular utility now that we're sort of in the thick of Ustekinumab biosimilar launches. And I think we're actually going to see different forms of Ustekinumab preferred across medical and pharmacy benefits because they don't talk as well. So kind of something to navigate up front. I'm still kind of processing how I feel about that, but a good way to see what's ahead. And having a designated sort of overseer of that process can help for overall decision making to integrate both of those sides. In terms of drawbacks, unfortunately, we can't predict everything. There are just unexpected changes that come up. We try to roll with it as best we can. I find that there's a lot of variation in turnaround time between medical benefit and prescription benefit prior authorizations. You may be left waiting for one of them. In my experience with a lot of the health plans that I'm dealing with in North Carolina, I feel like the medical benefit takes longer most of the time anyway. And so you might as well sort of have the sub-Q piece put into place while you're waiting on that. I think if the opposite is true, where you're sort of waiting on that sub-Q, you can sort of make an educated, decision there. It may add like a day or two if you're trying to wait on that outcome. But otherwise, I think if there's some urgency involved, you could potentially take an educated guess on, if you've got other backup items you could lean on. If for some reason things don't pan out the way you think, or they're a commercial patient, you could, use Bridge as backup, something like that. It does require a good working knowledge, I think, though, of medical and pharmacy benefit structures, and the ability to kind of put that together and relay that to a patient. I know for me, it kind of took me a while to pick up on the language of medical benefits. And sort of the second prong here is that MSOT, or multi-step order transmittal. This is a tool available in our EHR, so we use Epic, that can be sort of layered between the signing of a prescription order by a provider and the time that it actually hits a destination pharmacy. So it's basically like a creation of a holding tank of prescriptions, and we can sort of build criteria for what catches in that holding tank based on clinic context of our prescribers, with a grouper or like a list of targeted medications that you want to catch. And it shows up as a segment of the in basket, which is kind of neat. And you can work that as a queue. So on the left, you'll see an example of what my sort of basket looks like in this queue and the array of scripts that it catches. And then on the right is what it looks like in a patient's medication list in chart review. So you can actually see that the medication's in the list. It's been signed, but it actually says not released to destination if you scroll down. So that's a good, visual indicator for our support staff, to know that there's something being held somewhere, and we're working on something. You can also change the destination pharmacy on the back end when you release the prescription. That's a really neat function because it minimizes the need for complete, prescription reorders to change the destination. So an overview of this workflow, the prescriber will enter the orders for the IV to sub-Q medication. Our IV orders are placed through therapy plans, and then the providers get an alert inside the therapy plan to order the sub-Q component as a separate prescription order outside of that, and that is caught in the MSOT work queue for the pharmacist to see, and that sort of kicks off the whole workup of it all, and then we can track the new start. And we've decided that the timing of it is that we want to release the sub-Q prescription to the destination pharmacy at the point that the IV induction dose or series is completed. So MSOT has been a great tool for us, not just in the IV to sub-Q space, just in general, but we find that this helps really control the timing of the maintenance prescription in a way that minimizes confusion for the patient, the destination pharmacy, so they're not having to keep tabs on when the patient's getting their next infusion. It also makes it safer in the sense that we're minimizing the risk for overlapping here. We talked about the benefits of changing the destination pharmacy upon release, just based on insurance network and things like that. And this also pairs really well timing-wise with pharmacist counseling that happens at the only or the last infusion, which I'll talk about. And then there's not really many downsides to MSOT, which is great. This happens incredibly rarely, I think, but if the prescription is discontinued from the med list at some point in error, by even another clinic or something like that, it can remove that task from MSOT. But I found that there are other guardrails and time points in the process that would sort of alert you of something like that would have happened, and you can catch it fairly easily. And I think that it can be a little bit tedious to track sometimes where patients are in their infusion stage, but it's not too bad. It really only becomes tedious, I think, if we've got patients that are scheduling and rescheduling repeatedly their infusion appointments. So the last kind of prong of this process is our pharmacist-driven counseling piece. And we plan for a pharmacist to perform counseling at the patient's only or last IV induction dose, where the pharmacist goes into the infusion suite, visits the patient. We address several things as part of this counseling. We address timing of when to start the sub-Q, dosing thereafter, who and when to contact for getting those pharmacy fills, coordination of copay assistance if it's needed, and a good discussion of clinical expectations. And of course, this is a great time to also do injection teaching with a demo device. And I'm also very lucky in my practice that I'm physically located in the main GI hepatology clinic, which happens to also be in the same sort of like plaza as our two of our main system infusion suites. So it's all kind of wrapped up together, which is really nice. We end up capturing about 85 to 90% of IV to sub-Q patients at these sites. So that's great. But, of course, a small percentage either infuse at a satellite location or infusion suite within our health system, and then a very, very small percentage would be infusing totally externally. And then for those patients who don't infuse on site, I think you can still successfully conduct this intervention remotely at that time point. You just miss that physical interaction. I found that this really helps sort of smooth the process here to be able to tackle this list of items all at once with the patient. It's also a great use of chair time. The patient's already there for a set amount of time. You might as well go visit them while they're there and have a chat. This tends to be the most impactful, I think, for patients who are either self-injectable naive or are utilizing one of our more involved devices, such as the on-body injector. I think it's great to get that hands-on practice. And it's just a great time for questions and discussion. And I think the main drawback of this is that affects, applicability is that we're not going to capture 100% of patients in person. We may miss out on that face time, but I still think that can be successful if administered remotely. I think it would be challenging to implement in person for either very large systems with a broad array of infusion locations, or if you have like a hybrid or remote model. So takeaways here are that IV to sub-Q is part of our practice. It's here to stay. It remains complex. And, I think that if there were one great way to do it, we'd all be doing it. But there's just so many moving pieces to it and ways to structure it based on your institution's need. But I think top of mind has to be making sure the patient has a smooth process here. We're being good stewards of the therapies that we initiate to make sure that we have the best chance of continuation all the way through. Across institutions, of course, structures and processes vary a ton, depending on what your pharmacy team looks like, if there's different groups handling infusion versus pharmacy authorizations. And, I think it highlights a common thread here that we need effective communication across these groups and good handoff for this to be successful. And with that, thank you so much.
Alyssa, thank you for a fantastic presentation. I think we all agree that while the treatment advances have been great in the realm of IBD, that sometimes you have to think about the logistics of medication access. And of course, one of the things being obviously when you don't have the ability to access that treatment or have interruptions or need to abandon treatment, it can definitely be a pain point for sure. So we have one question come through, and then I have a follow-up question if we have time. Sure. But though there is one participant that has the MSOT in their clinic, and they mostly love it. They're wondering if you have any tips or best practices on helping others understand that functionality. They've had it for about 4 years, and they still have both nurses and dispensing pharmacists that just don't really understand that like process of how it works. And there's a lot of FTE burdens associated with it, like needing to hunt down where this prescription is, contacting the provider when they're trying to actively hold it while working on the prior authorization, waiting for like the timing of the sub-Q dose, etc. So they're obviously education we know is most impactful, and they're trying to do their best to do a lot of education around it. But just the overall turnover and just like the amount of work that goes into with the medication, it tends to be like an issue. So any perspective from that regards in terms of how do you get your staff to buy in and really make the best use of the functionality?
Yes, I think there's a lot to think about when you launch something like MSOT because of that piece of, when a patient calls into the clinic and you've got, nursing staff or other support staff or even providers that are looking at that medication list and wondering, where are we in this time frame of IVs to sub-Q? Why is it not released anywhere? Really, I think that visual of the not released to destination pharmacy that shows up in the med list is really the number one thing that we always direct our clinic staff to. And of course, that does take some buy-in and some getting used to of like really looking for that. I think it sort of eased us into that because our institution also had like EPA that also, if any of you have that function in Epic, works similarly. There's almost like a release point after that's worked. And so that was a little bit more of sort of like an on-ramp for us. But yeah, as much as you can sort of corral people and educate on what things really look like in that chart, and educate on the process. But we also have separate like telephone notes in our Epic charts that we sort of run that sort of helps track the stage at which we are in IV to sub-Q, what's approved, what's not. And so that's another way to sort of check. But I think there's a lot of ways you can structure MSOT, and it can kind of take a little extra time, but I think it's worth it to make sure that things are going to the right place at the right time.
Perfect. How did you become aware of that functionality? Was that something that you had to go about asking your IT team, or would you present the problem like, hey, we're having a lot of issues around with the IV to sub-Q conversion. What are some strategies from like an IT realm that you could help us with? Like, how did that come about?
Yes, so I heard about this initially through one of our other kind of specialty pharmacy consortium resources, and some folks were using this. I think initially in like the rheumatology space is where I heard about it first. And yeah, I think what kind of leads up to this is not only IV to sub-Q. In fact, I think IV to sub-Q was sort of like enhanced with doing this. But I think it has great benefits otherwise with just making sure that things are kind of buttoned up and ready to go. If you've got like additional baseline testing that you're waiting on, prior authorization is waiting. There's so many different, I think aspects that it can be used. But it's an option in Epic. We just had to approach our IT team to say, hey, can you help us build this out? And there is a little bit of an on-ramp, like time-wise, to building that out, because you do have to tell them, what clinic context you're looking at. I think for us, one of the things that we sort of missed was our GIs being in endoscopy suites too, when they're sort of like charting and sending some of these in. So capturing that, and then also kind of capturing that list of medications and constellation you want to capture.
Perfect. All right, Alyssa, so there is a few additional questions coming in for you
Sure.
from the question in our chat box. If you don't mind taking a few minutes to go through these, I think there's a lot of questions still surrounding the process of when you do like around the benefits investigation process, and do you ever like get any pushback if we have the maintenance dose not necessarily being approved because the IV hasn't been administered? So like, how do you handle that process? So would appreciate your insight if you could take a few minutes to answer those questions. But thank you again for an excellent presentation. Definitely a problem area, and so always like happy to hear about any solution here for sure. So on that note, I'm excited to hand it over to Erin. Erin Connolly, the floor is yours. Thank you.
So my name is Erin Connolly. I'm a pharmacist specialist in inflammatory disorders through the Brown University Health Specialty Pharmacy. I have nothing to disclose. Today we will be first these are my objectives. I'll be providing a background of our institution and team involved in this project. We'll then discuss identified need for this innovation and explain how it was implemented. Finally, we will discuss project limitations and future directions for this work. So before diving into today's topic, I'd like to provide some background on our institution and team. Like I mentioned earlier, I'm employed through the Brown University Health, which is our state's largest health system in Rhode Island. That is a bit of a hyperbole. We're the largest health system, but we are also the smallest state. Brown Health, formerly known as Lifespan, includes 5 hospitals and a range of primary care and specialty practices across our state in service area. 3 of our hospitals are in Rhode Island, 2 recently acquired in Massachusetts. Our service area spans mostly Rhode Island, but also southeastern Massachusetts and parts of Connecticut. The project I'll be discussing today is currently being implemented at 2 of our hospitals. I'll discuss briefly. Both of these hospitals are in Providence. Rhode Island Hospital is just over a 700-bed academic medical center. Miriam Hospital is about a 250-bed community hospital. The pediatric wing of Rhode Island Hospital, named Hasbro Children's, is an 87-bed facility and is notably the only children's hospital in our state. And yes, as I'm sure some of you are wondering, Hasbro is named after the toy company, which is also located here in Rhode Island. Now that I've introduced you to our relevant hospitals, I'd like to introduce you a bit to our team working on this project. So the Brown Health Specialty Pharmacy operates with 2 main arms, one operational, the other clinic-based. Both are rapidly expanding. Notably, we have at current state over 15 clinic-based pharmacists working across various specialty medicine service lines. Of those clinic-based pharmacists, 7 or just under half are embedded in our outpatient inflammatory clinics, including adult and pediatric gastroenterology, rheumatology, and dermatology. Pharmacist services have been integrated into these inflammatory clinics for over a decade now. In these settings, pharmacists function in a clinical capacity as part of our care team, working under collaborative practice agreements. Our pharmacy team also plays a critical role in ensuring medication access, supported by a dedicated technician navigator group. Inpatient pharmacists are also involved in the care of patients with inflammatory diseases during hospitalization, and more of a centralized capacity. With those introductions out of the way, we can dive into the project. As access to and understanding of advanced specialty therapies continues to grow, we've seen increased utilization of these drugs overall, and notable for our topic today, that use has also expanded within the inpatient setting. The core related issue that led my team to this project really boils down to a lack of a formal institutional protocol to ensure care continuity after biologics or other advanced specialty therapies were being used during a hospitalization. Once we identified this gap, it became a concern, particularly for our IBD pharmacist team, with special consideration to the context of an acute severe IBD flare and risks associated with gaps in therapy, particularly early on in the treatment course. As we all know, these are high-touch medications that require close monitoring and are often also unfamiliar to pharmacists or clinicians that may be interacting with patients during an admission that don't actually specialize in these inflammatory diseases. On top of that, these therapies come with complex access and authorization requirements. And as we know, starting a patient on one of these medications does mean navigating a series of time-sensitive steps as they're getting started. My next point deviates a little bit from this slide, but for added context, our pharmacy team really did start to dive into this discussion, and we started to identify a difference in the way that inpatient biologics were being considered or treated between our adult and pediatric GI clinics. This is, of course, at least partially related to the severe disease phenotypes pediatric patients may present with. But outside of disease severity in that clinical context, our pharmacists still anecdotally did notice a difference in how inpatient biologic was being treated between those 2 wings of our hospital. We felt that our patients seemed to have a smoother transition of care if they were, or our pediatric patients rather, seemed to have a little bit smoother of a transition of care process if they were started on a biologic during a hospitalization. So for example, if one of our pediatric patients was started on Infliximab during a hospital stay, we felt like it was more likely that they'd have their prior authorization in place and an appointment scheduled for dose number 2 at the time of discharge. And we just started to notice that this wasn't always the case in the adult setting. So kind of looking at what that could be related to, we think that the difference in structure of our clinics is likely related to the difference in structure between our pediatric and adult divisions at our health system. As I previously mentioned, Hasbro is the only pediatric GI practice in our state, and our providers care for most patients in our hospital service area. Our physical practice location is also located on our hospital's main campus, and this gives our PD providers more direct access to their inpatient care. Our pharmacy team is also located within that clinic space attached to the hospital, and we're more keenly aware of the GI services inpatient census on a weekly basis. This contrasts with how our adult service is set up. There are many adult practices within our state, and many are not affiliated with our institution. Some of the GI practices with privileges at our institution are also technically external to our health system and may not have an affiliated specialized pharmacist, and that can limit their capacity to ensure these collaborative transitions of care as the patient's being ready to be discharged. All of this to say, we identified the importance of involvement of a specialized pharmacist during these care transitions, and we also acknowledged that within our affiliated clinics, when these patients present for follow-up care after a hospitalization, it is usually one of our pharmacists who is starting to coordinate that medication access. So we have a rule within our pediatric clinic that as soon as a biologic is being discussed on the floor, the team will let the pediatric GI pharmacist know, and we'll start that off process right away. This has significantly improved our success with the prior authorization process, ensuring patients have reliable access to continuing these advanced IBD-directed therapies, and also helping our pharmacy team keep a foot in the door and make any necessary clinical interventions in a timely manner. Our inflammatory pharmacists function in more of an outpatient capacity, and because this is an outpatient-focused role, we're not rounding on these inpatients every day. We're also often able to promote cost savings by reducing the length of stay and also allowing for discharge once we know that their therapy is accessible, or if appropriate, intervening to defer the med start until to the outpatient setting after discharge, while still ensuring that that medication can be started promptly. We started to wonder if we could emulate that collaborative structure that we're used to in our pediatric GI clinic and find a way to notify relevant outpatient pharmacists of an inpatient biologic being prescribed, whether or not they were directly notified by the patient's rounding provider or the inpatient pharmacy during the hospitalization. The goal of this project really is rooted in the needs of our IBD patients, but the structure is able to be replicated across all inflammatory specialties, and we're utilizing it in our rheumatology and dermatology spaces too. So in close collaboration with our pharmacy IT team, we found a fairly simple answer to trying to make sure our inflammatory pharmacists were being notified of the biologic use during the hospitalization. This workflow was first implemented in October of 2024, first started at our larger hospital, Rhode Island Hospital, with the adult and the pediatric wings, and then in March of this year expanded to the other previously mentioned community hospital, the Miriam. When an advanced therapy is ordered on an inpatient MAR, a silent best practice alert, or BPA, which is a sort of Epic-based notification, triggers and sends a staff message to a designated folder in our shared pharmacist in-basket pool. The staff message populates the name of the ordered drug and the ordering provider's name. That message is then reviewed by our team's clinical pharmacist coordinator to identify the legitimacy of the order, whether or not it was actually planned to be administered. That coordinator then triages the service line that belongs to, and whether or not that patient follows with a health system affiliated specialty clinic. The coordinator then forwards that message to relevant outpatient pharmacists to confirm awareness of the ordered biologic, intervene as appropriate, and or facilitate that transition of care as applicable. So for example, if an infliximab was ordered, the pharmacist who's affiliated with that patient's care outpatient can immediately start that prior authorization process or intervene if they need to. At discharge, the pharmacist uses a uniform EPIC SMART phrase to document care transition information and how they intervened, and then routes back to our coordinator for tracking, and that data is compiled. So I'll share some of the preliminary trends that we've identified thus far. Between October 24, when this project was implemented, and May 25, when we last pulled the data, there were a total of 53 instances of inpatient biologic being ordered for patients at these hospitals. As one might anticipate, GI was the service line most frequently ordering these advanced therapies at just about 50% of all orders. The other category here mostly consists of nephrology and some neurology. Of the ordered therapies, half were infliximab, which is currently unrestricted on our inpatient formulary. Rituximab is also on our formulary. Upadacitinib is currently non-formulary, but is going up for review with P&T this fall. Tailing off of our previous slide, 23 of the 24 infliximabs ordered overall came from the GI service. The GI service also ordered upadacitinib 4 times, and 1 patient got an inpatient dose of Risankizumab. And then finally, this table aims to address how often patients admitted on the GI service achieved a successful transition of care as defined by authorization in place and confirmed 0 missed days of biologic therapy after discharge. This is stratified into 2 main groups: affiliated or non-affiliated providers. Non-affiliated providers are those whose outpatient practice is external to our health system. Of the GI patients who received advanced therapies, all who were able to be tracked start to finish did receive a successful outpatient transition of care. In one circumstance, the therapy was discontinued prior to hospital discharge, so they weren't able to be included. Notably, at current state, we are unable to track care transitions for unaffiliated providers as we don't have access to their electronic medical record. Limitations of this project included limited capacity to track data and potential for human error and reporting bias in the way that our data is currently being documented. These issues may be ameliorated if we're able to set up a process for this to be more automated. We're also hoping to eventually create a Power BI dashboard to track this a little bit more clearly. Data tracking is also limited, of course, to patients who follow within our health system due to limited access to other EHRs. We do eventually hope to create a workflow to follow up with unaffiliated offices to survey on appropriate transitions of care for non-affiliated patients that we can't currently track. And we do hope to continue to scale this project to our other affiliated hospitals in the coming years. And we hope to better track these data and trends through the use of Power BI and implement quality improvement projects to ensure appropriate inpatient biologic use. Thank you to an amazing team of pharmacists led by our clinical coordinator, Allison Zern, who was the one that built this structure and facilitates this project in its current state. This has very much been a group effort across all of our inflammatory pharmacists, and I'm glad to work on such a great team. These are my references, and I'm happy to answer any questions.
Thank you so much, Erin, as you presented all of this, and it was so relatable with what we're seeing as well. So, and I vigorously was taking notes. Also noted, you said a simple answer, and how often do we hear that? So, silent BPA, I'm taking note for that. One question that came in, I'll just read it here because I, again, relate to this so deeply, but when you're notified of an inpatient start, how do you or the team determine which provider the outpatient orders will be under? In our system, we have numerous inpatient GI providers that rotate, but our outpatient IBD clinic only has 2 providers. It gets logistically complex when the pharmacist CPA is only with those 2 outpatient providers, but they maybe haven't seen the patient yet, or the patient hasn't been seen in clinic. So then also the clinic nurse team might not deem them within their jurisdiction to assist with anything yet.
So that's a really great question. In terms of that institution does sound like a challenging structure. Within our institution, we are lucky that all of our providers in the outpatient clinics do take turns rounding up on the floor, and it is a very collaborative team. So my primary practice site where I'm taking charge of these care transitions is in our pediatric clinic. And we tend to, we have a CPA for all of our attendings and fellows. We will confirm with them prior to us starting to write those orders, but it does tend to come from their primary outpatient GI provider. And that provider tends to be aware of what's going up on the floor prior to discharge, which is why we like to use our PD clinic as like an example to try to emulate with our adult spaces, because that isn't always the case elsewhere. In those cases, it still probably will come from their primary GI if they have been seen already and they have care established. We will notify the provider first, confirm that plan, and if they need to intervene, they'll do so too.
Definitely different environments have different challenges to kind of overcome and identify a workaround or kind of how to proceed. Looking over here in the chat, this is a really great idea. We still run into issues where our GI fellows forget to tell us about these starts, and we find out because Walgreens or community pharmacy was clarifying an Upadacitinib ERX sent to their store. So I think we all can, hear stories where it's just too far down the line. Ideally, we would have heard earlier on. Another question here, can you please clarify who the clinical coordinator is? Is it a pharmacist or nurse? Can you speak more on how to follow up with unaffiliated patients when we are limited scope-wise and often needing a supervising physician?
Yes, absolutely. So our clinical coordinator, sorry for not clarifying sooner, is a pharmacist on our team. So she is a pharmacist, primarily practices in rheumatology, but helps to kind of broad strokes coordinate things across all of our inflammatory clinics. So this has been, something that we brought to her, and then she was able to run with and work with IT to kind of create the structure. And then to speak to follow up with unaffiliated patients, that continues to be a challenge, but we are still very grateful that we're being notified of these, the medication being started, because our team, even though we aren't directly related, will take it upon ourselves to reach out to the unaffiliated clinic and let them know that this medication is being started on the floor, or that the team is looking to start it. So for an example, something that comes up quite a bit is, say they're looking to start a JAK inhibitor for a patient up on the floor, where that team does need to ensure that they have a prior authorization in place prior to being discharged, so the patient's able to continue on and not have any gaps or days with gaps in therapy. We'll call the clinic, help them, make them aware of that so that they can get that prior authorization in place and kind of guide them from afar if they need any help.
That's wonderful to hear. I know, we always have to start somewhere, but kind of taking those extra steps for those patients who maybe aren't affiliated, but of course do need that ongoing care. So to be able to kind of be that bridge and communication is so important.
So good morning. My name is Shannon Pache, and I practice at Mayo Clinic in both the dermatology and IBD clinics. So as we get started with today's presentation, there are many directions you can take when discussing the management of coexisting immune-mediated diseases in IBD, rheumatologic, hepatic, pulmonary, just to name a few. But for today's talk, I'm focusing on the skin. Given my practice spans both IBD and dermatology specialty clinics, I'm in a unique position to see how skin disease impacts our IBD patients. These conditions can significantly affect quality of life in both adult and pediatric patient populations and often complicate treatment decisions. So today we'll walk through how to differentiate these overlapping conditions, evaluate therapy options, and build treatment plans that reflect both clinical appropriateness and patient priorities. I wanted to take a moment to step back and clarify terms that often get confused in clinical practice, but are important points for distinction. Extraintestinal manifestations are complications that arise outside of the GI tract, but are part of the IBD disease spectrum. Think pyoderma gangrenosum, inflammatory arthritis, and PSC. Certainly things that we encounter every day in talking with our patients. These conditions tend to parallel gut activity and often improve with IBD control. In contrast, the focus of today's presentation is management of coexisting immune-mediated inflammatory diseases, which are separate diseases that often occur more frequently in patients with IBD compared to the general population, but do share common pathogenic mechanisms and require their own management plans. Examples, which are not all encompassing, but again, ones that we see commonly in practice, include rheumatoid arthritis, hidradenitis suppurativa, and multiple sclerosis. In crafting any talk, I think it's important to take a moment to understand why we care. Why is it that we want to sit and talk about this today in our IBD pharmacist meeting? So setting the stage, about 3 million adults in the United States have IBD. Of those, pending which report you look at, about 22.5% may also have some coexisting immune-mediated inflammatory disease. That means nearly 1 in 4 patients that walk through our clinic doors may require dual disease management. These patients are clinically complex for a variety of reasons. The presence of concurrent immune-mediated inflammatory diseases is associated with a more aggressive disease course in IBD patients, including increased need for immunomodulators, biologic therapies, and higher overall surgical risk. Further, the subset of patients can easily fall through the cracks if we're not systematically screening for overlapping conditions or coordinating care across specialties. In taking a look at why it is that patients struggle with not one, but potentially multiple immune-mediated inflammatory diseases, I think it's important to set the stage in looking by way of illustration at the shared pathophysiologic mechanisms between IBD and certain dermatologic immune-mediated diseases. Obviously, the list that I've highlighted here is not all-encompassing, but in the span of a brief talk, I've chosen 3 conditions to focus on in discussion: psoriasis, hidradenitis suppurativa, and atopic dermatitis. Here in the graphic, you see the multifactorial contributors to both gut and skin inflammation, which all interact to affect inflammatory response. These processes are not organ-specific, rather they manifest across epithelial surfaces, including the intestinal mucosa and the skin. Psoriasis is one of the most frequently co-occurring dermatologic conditions in patients with IBD, affecting approximately 3 to 10% of patients, with prevalence higher in Crohn's disease. Hidradenitis suppurativa is historically under-recognized in the general population and seems to uniquely impact patients with IBD. Recent data estimate its prevalence in IBD at approximately 5 to 10 times higher than the general population. It appears more commonly in Crohn's disease, particularly in women, and may present with perianal involvement that mimics or coexists with fistulizing disease. Atopic dermatitis is also noted to occur more frequently in patients with IBD, particularly the pediatric and young adult populations, which can be challenging given limited FDA labeling for treatment options in pediatric patients. I want to take a moment to orient you to this table that we'll return to throughout the talk. It helps us visualize which advanced therapies are FDA approved for IBD, psoriasis, hidradenitis suppurativa, or atopic dermatitis, and where they overlap. On the left-hand side, you'll see the various classes. This is not all-encompassing for agents available to treat dermatologic conditions. Instead, I focused on medicines approved for treatment of IBD and highlighted where they align in treating the dermatologic diagnoses we are discussing today. The asterisk designates agents that also have pediatric labeling. As pharmacists, this is certainly our sweet spot. This is where the magic happens, working with patient and care team to find therapeutic alignment amongst the variety of conditions that we're looking to treat in our patients. In going through the conditions that we're talking today, I'm going to start with psoriasis, and I thought that might be nice to work through a case in which I would just about bet that everyone has experienced in clinic. So, a 37-year-old female with a history of moderate to severe ulcerative colitis in remission on infliximab. Patient's been on therapy for about just over a year with a therapeutic steady state level. Past medical history is overall unremarkable and has been on a couple therapies in the past. She's presenting today to dermatology clinic after referral from her IBD provider with a 2-month history of new onset skin lesions characterized by erythematous scaly plaques over the scalp, arms, and extensor surfaces of the elbows, about 4% body surface area. The lesions are pruritic and flaking with no prior history of psoriasis, so that's an important piece, and no joint pain or nail pitting is reported. The dermatologist gathers history from the patient, clinically examines the patient, and then does a biopsy. In following up on all that information, has made a diagnosis of paradoxical psoriasis, likely secondary to anti-TNF therapy. I think it's important here to take a step back and consider what a paradoxical reaction is, given it's a term that is often thrown around in practice and not necessarily unique to this example. In medicine, we define a paradoxical reaction as the appearance or exacerbation of a pathological condition that typically responds to the class of drug being used while treating a different condition that usually remains uncontrolled. So in this case, TNF inhibitors, which are effective treatments for both psoriasis and IBD, can paradoxically trigger psoriatic lesions in some IBD patients. From a clinical perspective, this is a well-established phenomenon. Paradoxical psoriasis occurs in about 5 to 10% of patients treated with anti-TNFs and typically appears about a year to 18 months on therapy. A study by Froehling and colleagues, found that nearly 88% of patients who developed paradoxical psoriasis were in clinical remission from their IBD, underscoring that these skin manifestations often arise even when gut inflammation is well controlled. This is especially disheartening given we work so hard with our patients to get to that end goal of remission. So you think that the battle is getting past the acute management of the IBD into a state of stability, only to encounter a problem that threatens that fine balance of efficacy and tolerability. What's next in terms of management in this case and in other cases in specific? I think first and foremost, it's important not to be reactionary. Gather clinical information and consider key clinical pearls. So with skin conditions in general, I think that the nice piece about management is that oftentimes mortality isn't the problem. Rather, it's some degree of morbidity and patient quality of life. Not that that's not important, but I do think that that is important perspective in terms of how quickly and things need to be managed. Um, while the first thought might be to change to a different anti-TNF, given that this patient experienced control of ulcerative colitis on this specific mechanism, this strategy in general should be avoided. Paradoxical psoriasis is considered to be a class effect, and studies have shown that more than 50% of patients who switch to another TNF inhibitor will experience recurrence of symptoms. Instead, one should first maximize topical therapies as an initial approach for mild to moderate cases. These can often control symptoms without requiring systemic changes. For more extensive or refractory disease, traditional oral psoriasis agents like methotrexate or apremilast can be considered, though data suggests that efficacy in management of paradoxical psoriasis tends to be limited in this specific setting relative to traditional psoriasis. Importantly, oral corticosteroids are not recommended for managing psoriasis or paradoxical psoriasis in general. They pose a high risk for rebound flares once tapered and can complicate both the dermatologic and IBD picture. Ultimately, the decision to stop or switch biologics depends on the severity of symptoms and the impact on patient quality of life. If the skin disease becomes unmanageable despite topicals and adjunct therapies, a change in biologic class may be necessary. As with any good pharmacist, I enjoy an algorithm, and so I created a little algorithm here to help us walk through approach to treatment making and decisions, particularly when a change in biologic therapy should be considered. The first step is to assess the severity of the skin involvement. For patients with mild to moderate paradoxical psoriasis on the left-hand side of the screen, typically less than 10% body surface area, so where our patient falls. The approach hinges on whether IBD is controlled. If the patient's IBD is well controlled, we should start with topical corticosteroids with or without phototherapy. If their IBD is not well controlled, the first step is to optimize their IBD therapy through dose change of the anti-TNF or different agent, while still using topical therapies to manage the skin disease. In looking at the right-hand side of the screen, for patients with more severe paradoxical psoriasis, defined as greater than 10% body surface area or involvement of sensitive areas like the face, scalp, or genitals, the bar is lower for escalating treatment. If IBD is under control, a short trial of topicals and phototherapy may still be reasonable, but switching biologic class is also on the table even at this stage. If IBD is not controlled, we typically move directly to changing the biologic and supporting with topical treatments. In both pathways, the key is reevaluating response. If the skin disease doesn't respond or worsens despite topical and supportive therapies, that's when we should more definitively consider a change in biologic therapy. Moving on to our next condition for discussion, hidradenitis suppurativa. I think that this is something that I work particularly close with in the dermatology clinics and have very much seen in our IBD patients. HS is a chronic inflammatory skin disease characterized by painful nodules, recurrent abscesses, and sinus tract formation. These typically occur in intertriginous areas such as the axilla, groin, or perianal region. What makes this disease particularly challenging in IBD patients is that the clinical presentation of HS can closely resemble cutaneous or perianal Crohn's disease. Taking a look at the image on this slide, on the left we see perianal fistulizing Crohn's disease with deep sinus tracts and inflammation extending from the rectum. On the right, we see perianal HS, which also presents with abscesses and draining tracts, but these arise from the skin and subcutaneous tissue, not the bowel. Distinguishing between these two conditions can be very difficult, even with imaging or biopsies, and many patients may actually have both conditions. This overlap creates a true diagnostic dilemma and complicates treatment decisions. Presently, there are only 3 biologic options that are FDA approved for treatment of severe HS: adalimumab and the IL-17 agents secukinumab and bimekizumab, which are contraindicated in patients with coexisting IBD, leaving effectively one treatment option that is FDA labeled for treatment of HS with coexisting IBD. In looking at this contraindication more closely, in the physiological state, IL-17 plays a role in maintaining the intestinal barrier and supporting the immune response to infection in the GI tract. When you block IL-17, it is possible to see worsening inflammation in the gut instead of improvement. This rationale goes beyond theoretic concern and has been well documented in the literature. A phase 2 trial of brodalumab in Crohn's disease was stopped early due to worsening disease activity and lack of efficacy. Similarly, a proof of concept trial with secukinumab in Crohn's failed. Results actually favored placebo, and there was a high rate of response, or there was a high rate of adverse events in the treatment group. Further, a 2023 FDA adverse event report analysis found 268 cases of new or worsening IBD linked to IL-17 inhibitors, with secukinumab showing the strongest signal. Bottom line, IL-17 inhibitors are generally considered off the table in patients with IBD. This poses a major treatment limitation when managing overlapping dermatologic conditions where IL-17 agents are otherwise highly effective. In going back to the drawing board to figure out effectively what's left, as I mentioned, the anti-TNFs ultimately become a mainstay here when we review overlap and labeling. While adalimumab has formal labeling, infliximab is generally a well recognized treatment option in HS. I will also point your attention to JAK inhibitors, where I have the yellow arrows, and that will become a point for discussion in the next few slides. When it comes to managing anti-TNF agents in patients with IBD and HS, there are a few key disease-specific considerations to keep in mind. From an IBD standpoint, infliximab is often favored, especially if the patient has both HS and ulcerative colitis or HS and perianal Crohn's disease. Dosing is another major point. HS typically requires higher or more frequent dosing for both adalimumab and infliximab than we use upfront for Crohn's or UC. So, if we're targeting both diseases, we may need to dose to the HS, not the gut. Therapeutic drug monitoring becomes especially relevant in this setting. We routinely use proactive TDM and IBD, but there's historically been less data for dermatologic diseases. That said, we're seeing a growing body of evidence suggesting higher anti-TNF levels may correlate with better outcomes in HS. In fact, Chen and colleagues performed a prospective study that stratified adalimumab trough levels by clinical response in HS. As you can see in the table, patients with partial or high response in improvement in their HS had much greater steady state trough levels than traditionally associated with efficacy in the IBD literature. It was quite striking to see high response rates in patients that had median adalimumab trough levels of 24. This ultimately raises the clinical question with adalimumab in HS is more better. And for patients with both IBD and HS, it's something to strongly consider, keeping in mind that HS literature supports adalimumab off-label optimization up to 80 milligrams weekly. This table gives a snapshot of emerging data around JAK inhibitors in treatment of HS. While still investigational, these agents are showing promise. Upadacitinib in particular stands out given its dual indication in IBD and efficacy signals in HS. Topical JAK inhibitors also represent an interesting potential theoretic use, including the commercially available topical ruxolitinib. I think that it's particularly of interest in more mild cases of HS, as well as potentially cutaneous Crohn's disease that is not controlled on the current systemic therapy, or cutaneous Crohn's without significant luminal involvement. It will be interesting to see if more data in the future. Be interesting to see more data in the future, as the depth of absorption of the topical is likely the limiting factor in efficacy. Overall, these findings position JAK inhibitors as a potential dark horse in managing patients with both IBD and complex dermatologic manifestations, filling a key gap when anti-TNF therapies aren't enough and we're not able to use IL-17 agents. Next, we'll move on to a case of atopic dermatitis. So here we have a 28-year-old female with moderate to severe Crohn's colitis on Entyvio. The patient does have a past medical history notable for atopic dermatitis. In looking at information related to Crohn's course, patient overall is doing well on the Entyvio. It was recently optimized to every 4 weeks. But patient is seen today, notably in the dermatology clinic, for significant worsening of atopic dermatitis over the past 4 months, with new widespread eczematous plaques involving the face, neck, flexural surfaces, and trunk. Severe pruritus is interfering with sleep and quality of life, refractory to optimized topical therapies, including mid to high potency corticosteroids, tacrolimus ointment, and daily moisturization. When we're managing patients with multiple immune-mediated conditions, it's important to approach treatment with a clear and consistent framework. To work through this case, I've created a checklist to help anchor our decision-making when considering the patient presentation and available treatment options. This system can be applied to other scenarios too, whether it's HS, psoriasis, or even extraintestinal manifestations like arthritis. In any case, the key is to align the treatment plan with the dominant clinical problem while maintaining adequate control of the coexisting condition. Identify and treat the dominant disease. This means assessing the severity of each condition individually and defining treatment goals based not just on clinical data, but also the patient's lived experience and what they want from therapy. Our patient currently has good control of her Crohn's disease, but her atopic dermatitis is active and poorly controlled despite ongoing topical therapy. It's causing meaningful morbidity and clearly requires escalation in treatment. This helps define our goal. We want to initiate a systemic therapy that effectively addresses atopic dermatitis without compromising Crohn's disease stability. The next step is to align treatment across all of the patient's conditions. Whenever possible, we want to take a two birds, one stone approach, choosing therapies that can target both the gut and the skin. It's also important to be mindful of dosing discrepancies between indications. So if you're using a shared agent, be intentional about selecting the dose that matches the highest need. And finally, don't forget topical therapies for both the IBD and the skin. This table highlights advanced therapies for atopic dermatitis to help us consider options for our patient. As previous, the asterisk denotes agents approved for pediatric use. As you can see, a number of therapies are approved for atopic dermatitis, but very few have labeling that extends to Crohn's or ulcerative colitis. Upadacitinib stands out as the only agent in this matrix that is FDA approved for both Crohn's disease and atopic dermatitis, so that is an option we can entertain. The other strategy would be to pair a patient's current Crohn's-directed therapy, vedolizumab, with a systemic therapy for atopic dermatitis. You'll notice a few IL-13 or IL-4/13 inhibitors listed. While these agents are all approved for atopic dermatitis, dupilumab is by far the most established in terms of real-world experience, safety data, and breadth of clinical use. That's why for the rest of the discussion, we'll focus primarily on conversations surrounding the combination of vedolizumab and dupilumab as the reference agent for this class. Circling back to our checklist, we've now identified two potential treatment strategies: combination therapy with vedolizumab plus dupilumab, which would allow us to maintain Crohn's control while escalating therapy for atopic dermatitis, or monotherapy with upadacitinib, which has FDA labeling for both Crohn's and atopic dermatitis. Now we shift to the third item on our checklist, avoiding therapies that may create conflict between conditions. This step is especially important in patients with multiple immune-mediated diseases. Some treatments may benefit one condition, but have the potential to worsen or even unmask another. Classic examples are those that we've already mentioned here: use of anti-IL-17 therapies in IBD, as well as corticosteroids in psoriasis. In looking at this particular case, dupilumab, an IL-4, IL-13 inhibitor, it does raise some theoretic concerns, though there is no firm contraindication to use in IBD. We know that IL-13 plays a role in the gut epithelial barrier function, and although data are limited, there are a small number of reports in the literature suggesting a possible association between dupilumab use and new onset colitis, though again, no firm contraindication for use. And there's also literature to support efficacy without safety concerns that we'll review here shortly. So ultimately, just an important point for monitoring. When we're treating multiple immune-mediated conditions, it can be tempting to layer therapies, but that comes with real risk, especially infection, malignancy, and organ-specific toxicities. Whenever possible, we want to use the narrowest spectrum immune suppressive agent that still achieves disease control. That means selecting targeted therapies rather than broadly immunosuppressive regimen. And most importantly, as we all know, prevention is key. As a number of targeted options continues to expand, our responsibility isn't just to treat disease, but to do so in a way that's safe and sustainable. So let's consider our proposed treatment options. This slide shows a simplified safety spectrum, considering each agent individually, with vedolizumab and dupilumab generally considered to be among the safest agents, particularly from an immunosuppression standpoint. Upadacitinib, while effective for both diseases, sits further along the safety spectrum due to its broader immune modifying effects. In terms of real-world experience, combination therapy with dupilumab in patients with IBD has been reported as effective in treating dermatitis with no notable adverse events or signal for IBD worsening. There are also data from other disease states where dual therapy with dupilumab has been safely used alongside other systemic biologic agents. When it comes to practical considerations, avoid live vaccines during treatment with dupilumab, but otherwise there are no significant changes to standard immunization schedules. And importantly, dupilumab is considered safe in pregnancy and lactation, which may make it an attractive option in certain patient populations, as is the case with our patient, a young female of childbearing age. At this stage, we've thoughtfully worked through our decision-making framework, and both vedolizumab plus dupilumab and upadacitinib monotherapy remain clinically sound and safe options. This is a clear opportunity for shared decision-making, a step that's often the most meaningful, particularly in a population where empowering patients to take ownership of their treatment journey can enhance engagement and outcomes. The aim here is to collaborate with the patient in choosing a path that aligns with their goals, preferences, and lifestyle. Whether that involves considerations like route of administration, safety in pregnancy, or their level of comfort with immunosuppressive therapies. It's not about dictating a therapy for the patient, it's about building a treatment plan with the patient, grounded in clinical appropriateness and personalized care. So at this point, to wrap things up, I think this graphic does a nice job of highlighting the unique role clinical pharmacists play in navigating complex treatment decisions, especially when managing patients with overlapping immune-mediated conditions. At the center of our work is always the patient, and surrounding them is a framework where we can have real impact. Ultimately, our value lies in bridging the gap between therapeutic complexity and real-world patient care.
I'm fortunate to be partners in crime with you in clinic, and you've brought so much expertise for these overlapping conditions. A couple of questions that have come in. For paradoxical psoriasis, what are your thoughts on increasing the dose of the anti-TNF? Can this be effective in treating the paradoxical psoriasis?
So generally speaking, if it is true paradoxical psoriasis, I would say likely not, because ultimately it's thought that by inhibiting the anti-TNF, that's actually part of the propagation of the paradoxical psoriasis. Now, if you have uncontrolled actual underlying psoriasis, then it could potentially help. But that's where it's kind of working close with the dermatologist team to sort out the actual underlying mechanism.
Thank you. Is there any safety data for combining topical JAKs for a derm condition while also using something like an anti-TNF or IL-23 for the IBD?
Um, so I do not believe that there is any published data on combination therapy with the topical JAK inhibitors, though I have seen it in clinical practice in the dermatology setting for patients that have labeled reasons to be on the topical JAK inhibitor. And overall, there is very little systemic absorption of the topical JAK inhibitor, especially when used over small surfaces. So I would say that overall it is a safe strategy.
Thank you. And then I'll just point you to the chat for one additional question that did come to my mind too, for kind of the dual medications and the insurance side of things, although identifying that they're for two different indications. So if you can answer that, that would be wonderful.
Thank you.
Thanks, Shannon. And now it's my pleasure to turn it over to Lisa Woolard as well as Natalie C. from Emory Healthcare.
Okay, so just wanted to reintroduce myself. I am Lisa Woolard, and I'm working with my colleague, Natalie C. We are both the gastroenterology clinical pharmacy specialists at Emory Healthcare, and today we are going to be discussing measuring life beyond symptoms, quality of life simplified. You can see our disclosures on this slide, and the objectives for our talk today are to understand the importance of quality of life as a target of therapy in inflammatory bowel disease, to discuss the challenges with currently available quality of life tools, and to explain how quality of life is tracked within pharmacist-led visits at Emory Healthcare. I know we are all familiar with this pictogram with the STRIDE Selecting Therapeutic Targets in Inflammatory Bowel Disease program that published a consensus statement in 2015 on treat to target strategies, with the primary therapeutic goal at that time being clinical and endoscopic remission. This was updated in 2021 with the STRIDE 2 guidelines that now provide the most current recommendations for treat to target approach in patients with inflammatory bowel disease. STRIDE-2 confirms that the most important long-term achievable treatment targets for patients with IBD are not just clinical remission and endoscopic healing, but now include restoration of quality of life and the absence of disability. So how did we incorporate the STRIDE-2 initiative into practice at Emory Healthcare? In October 2022, Emory switched their electronic medical record from PowerChart to Epic and launched Compass Rose as our platform for managing specialty pharmacy patients. Additionally, a quality of life assessment question where patients rated their quality of life as low, moderate, or good was added to our outreaches based on York accreditation requirements. This was further expanded in April of 2024 with a leadership initiative to define targets of therapy to align with URAC standards requiring every drug dispensed from a specialty pharmacy to be tied to an outcome. Each specialty area was tasked with determining their own outcomes. I considered the various objective markers that I could follow. C-reactive protein, however, that's a nonspecific marker and may not always correlate with disease progression. Fecal calprotectin, definitely a specific marker, but many times is a limitation since most patients do not want to complete. Endoscopy scores, probably not really easily measured within our realm as pharmacists, since they many times only happen once or twice a year. But then I remembered a presentation from AIBD that I'd attended in that previous December that highlighted Corey Siegel's article from 2018 called Refocusing IBD Patient Management: Personalized, Proactive, and Patient-Centered Care. The hierarchy of needs pyramid had been transformed into what was important to patients with IBD may not always correlate with what was important to physicians. So how could I find a tool that can monitor the patient-focused outcomes? I began researching the various quality of life tools that were available for IBD patients. And here's a sampling of some of the tools that are found: the IBDQ, the SIBDQ, the CUCQ32, and the CUCQ8. There are actually 4 domains within both of the IBDQ and the CUCQ tools. Both types encompass social and emotional functions, but the IBDQ includes bowel symptoms, whereas the CUCQ includes physical symptoms. All of them actually utilize a 7-level Likert scale, except for the CUCQ32 and 8, which use a 4-level Likert or ordinal format. The score range is from worst to best, so the lower the scores on the questionnaire, the worse of the symptoms. Additionally, we looked at pediatric tools. The Impact-3 and the PEDS-QL GI are both tools utilized within the pediatric arena, but note that the PEDS-QL tool is not actually IBD specific, but rather applies to general GI patients. These tools can be patient or parent reported. The Impact-3 tool contains 6 domains that include bowel symptoms, systemic symptoms, social functioning, body image, treatment interventions, emotional functioning. There are 35 questions with a 5 Likert scale. In contrast, the PEDS-QL includes multiple domains, including food and drink limitations, stomach pain, gas and bloating, worry about bowel movements, worrying about stomach aches, to name a few. So let's dive in a little bit deeper into some of these actual questions. Let's look at a question 1 from the SIBDQ sampling. How frequent have your bowel motions been during the last 2 weeks in comparison to when your disease is stable? More frequent, extremely frequent, very frequent, moderate increase in frequency, some increase in frequency, slight increase in frequency, or no increase in frequency. Also, let's look at question 3. How much of the time in the last 2 weeks have you felt irritable in mood? All of the time, most of the time, a good bit of the time, some of the time, a little of the time, hardly any of the time, or none of the time. Looking at the answers, I think patients may have a difficult time judging between some and slight in question 1, or possibly in question 3, some and a little. Moving on to the PEDS questionnaire. I feel pain or hurt in my stomach. I get stomach aches. My stomach aches. I wake up at night with stomach aches. I feel sick to my stomach. I get an upset stomach. Once again, as a teen, how are you going to differentiate between I get stomach aches and my stomach aches? Another example of food and drink limitations. I cannot eat some of the foods. I cannot drink some drinks. I'm not able to eat what I want. I'm not able to drink what I want. I cannot eat because some foods, they make me sick. And I cannot eat the foods that my friends eat. So all in all, there are just too many questions. And I think that we can all agree that these questionnaires can be overwhelming for patients. And despite them being validated tools, they can be cumbersome to perform and utilize in clinical practice. So based on these complexities that I saw in these validated tools, I began to wonder if I could try to track these quality of life outcomes without a tool. I sought advice from fellow colleagues in pharma and at other institutions, and I thought about the various concerns that patients had mentioned during our visits over the years, and I created multiple categories. The number of categories started accumulating, so we ended up merging some of the categories. In August, we began utilizing discussing targets of therapy with patients based on the categories that I had chosen. And then in December of 2024, a formalized tool was actually created in Epic to document these goals within our note template. And this is what it actually looks like. Patients are asked to rate their quality of life in regards to their disease state, and based on the response, the conversation flows naturally to discussing ways in which their therapy can help to improve or possibly maintain their current day-to-day quality of life. Their responses are categorized into the 7 categories that you see here. The goal is then assessed at each follow-up visit as making progress, no change, or achieved, or it's sometimes regressed. Additionally, there are target comments that allow us to enter information regarding the specifics surrounding the goal. Here's an example. Patient related 7 to 10 is their quality of life. They chose the goal of reducing symptoms. They're currently making progress. The patient would like to be physically pain-free on her bottom area and not rely on ibuprofen or a cushion pillow. And today she reports that she hasn't used or needed ibuprofen in a while. Additionally, patients can choose multiple goals and add on a goal at another follow-up visit, such as this patient who is making progress on reducing symptoms, but has now added the goal of improving nutritional status, dietary intake. So that goal is now in the initiated phase. I am now going to turn this over to Natalie to discuss our quality improvement project that actually reviewed and utilized this tool, or the utilization of this tool.
Thank you, Lisa. So before I dive into the outcomes from our project, I do want to share some insight in terms of how our pharmacy visits are set up. So for our initial visits with patients, this is where we review and counsel patients on their therapies. And then we decide when we would want to follow up with them, which could range anywhere from 2 weeks to up to even 2 months. And this is really to allot time for medication access related items like prior authorization, as well as taking into patient factors. For instance, some patients may prefer to be seen sooner at the time when they do their first dose in clinic, and then also taking into account the treatment parameters. When would they transition from the induction to the maintenance dose? So taking that setup into account alongside our own internal deadlines for our QI project, we opted to only review patients that were newly started on a advanced therapy that had at least 1 follow-up visit within a 6-month window. So between August of last year till February of this year. So that generated a total of 365 patients with over 500 visits. We then, based on that inclusion criteria, that dwindled down the number of patients to 40 unique patients. To your right are some of the baseline characteristics. As you can see here, 75% of patients had Crohn's disease, 25% had UC. There were a small number of patients that had other autoimmune diseases, which could impact their quality of life responses. And then at the bottom, about half of the patients had at least more than 1 quality of life target or goal that they would like to achieve. So moving towards their quality of life scores that they responded from the initial and the last follow-up visits, which are reflected to your left and right-hand side accordingly. So for the initial visit, 25 patients of the total 40 reported having a good quality of life score, which is a score of 7 to 10 out of 10. And then 13 patients reported having a moderate quality of life score, and then 2 with low quality of life scores. You can see the same, frequency of responses with the follow-up visit, with a slightly larger number of patients reporting having a good quality of life and less number of patients reporting a moderate quality of life score. With regards to the categories expressed that they would like to, work towards too, these 5 listed here are what these 40 patients made note of, but just keep in mind what Lisa mentioned previously, we did have 7 different categories. The most common one being reduced symptoms as anticipated, followed by overcoming certain work, school, social, and/or mental health related barriers. So in terms of quality of life targets at their follow-up visit, besides detailing which goals they would like to work towards they can also report how they're progressing towards those goals. So if we were to look at the first row here with the goal of reducing symptoms, of those 30 patients, 15 patients reported having improvements in symptoms, 12 patients reported having no change essentially, and then unfortunately we had 3 patients who report worsening symptoms or which we marked as regressed. Note that we can add additional goals that patients would like to achieve that maybe they didn't mention in the initial visit or the previous visit. So those are highlighted in the light teal here. So if you were to look at the second row with overcoming work, school, social, mental health related barriers, of those previous patients from the initial visit, those 10, 6 of them reported making progress, while the remaining said that there wasn't any changes thus far. And then 4 new patients added that as an additional goal that they would like to achieve. For the remaining categories, majority of the responses was that there wasn't really any change. And then we had 1 patient, as seen at the very bottom, who was in clinical remission. And so their goal was to maintain clinical remission. So as you can see here, we are able to document and track patients' responses in terms of their quality of life successfully. And we also wanted to highlight the utility of it with a few patient cases. So the first one here is a 53-year-old female with Crohn's disease who was referred for Guselkumab therapy. At the initial pharmacy visit, the patient had recently received their IV induction, but she was still complaining of several symptoms, including abdominal pain, frequent bowel movements, and urgency. And they also reported a moderate quality of life. One of the things that this patient specifically mentioned was she enjoys singing, singing in gospel music and all that. And unfortunately with singing, she does have to exert herself, which then leads to accidents. And unfortunately, these accidents and urgency, keeps her restricted and she's always stressed about having to have an emergency bag with her. So we categorize her goals as reducing symptoms as well as overcoming social and mental health barriers. On her follow-up visit, her symptoms have improved. She reports having a better or a good quality of life. And she was actually thrilled to share how, she had no accidents. She was able to sing at her cousin's funeral. And in addition, she also felt like she had more energy. So overall, she was making progress in these 2 goals. Moving on to our second patient case, which is a young female with ulcerative colitis that was referred for Upadacitinib therapy. Her main symptom complaint was the urgency. She reports having a moderate quality of life. And specifically, this urgency is leading to accidents at work and also, exacerbating or coinciding with her anxiety. And so similar to our previous patient, they had the same goals of reducing symptoms and overcoming work and mental health barriers. For her follow-up, she did express significant improvement in symptoms and having a good quality of life. Unfortunately, we find out that she's actually working at a dermatology clinic and she was having the adverse effect of persistent acne with Upadacitinib, and it was affecting her confidence and her ability to be present at work, that she actually asked to see if we could change her treatment despite how much improvement she was having with her ulcerative colitis. So that resulted in us changing her treatment to tofacitinib. And then anecdotally, we've also gotten a lot of positive responses from patients, just appreciating us asking about their quality of life and how they're doing day to day, and also appreciating how, they didn't realize we had other resources in clinic available, such as a dietitian. So in summary, quality of life is an important target of therapy. And even though the tool that we created was not validated, it is a simple tool that we were able to incorporate to encourage patients to track and work towards their own goals. And quality of life discussions, lastly, allow for meaningful conversations that can aid with therapy decisions and collaboration of care. And so I hope we inspired you to think about ways to incorporate quality of life assessments with your practice, and would like to open the floor for any questions.
Thank you so much for that innovative presentation. I think sometimes from a day-to-day standpoint, we tend to get very bogged down in terms of clinical endoscopic remission, kind of hitting the treat to target. So I think it was just really great to kind of think about thinking beyond that and thinking about quality of life. And this is something that's super important at our pharmacy as well. This is discussion we're having every day about what are some of the ways we can better incorporate quality of life and kind of things like that. So thank you so much for this great example and kind of what you've been doing at Emory. So we do have a question. Is there any tool asking for diet? Is that something that you all have looked at or considered?
So we were focusing on quality of life, and so sometimes some of these questionnaires have domains that does touch upon some of these things in relation to diet, but I am not familiar of a specific questionnaire that just looks into diet alone specifically. We might have to ask our dietitian if there is such, an item. Yeah.
Yeah, and I think you kind of mentioned just through these questions of identifying other members of the team that maybe you could refer patients to or get them connected with just to kind of help, provide that holistic patient care. In the last couple minutes, I did have a personal question in regards to this, and it's kind of related to who you are doing this for. Are these only for patients you're filling for, or is this all IBD patients that comes under pharmacist management?
That's actually a great question. We have we handle every new start patient. So even if we have to transfer the medication out, so all new starts come through myself or Natalie. And so we are moving forward. We're going to be trying to at least follow all of our new starts for at least the first 3 to 6 months. And then even if they are transferred out, as we're developing other workflows for other things to be taken off of our plate. So I think that that's a great question. So it isn't just Emory Specialty Pharmacy patients.
Perfect. There's another question that popped up. Maybe this will be kind of the last question before we move on to the next presenter. But with quality of life conversations, I suspect needs are revealed that require follow-up, mental health concerns, diet, so forth. How have you prepared for these concerns and needed resources?
I think we do, we do have a dietitian within our clinic, and then we can actually refer them out. I think that they do bring up options for us to, ensure or look to see if there's any type of mental health that we can refer them to. We currently don't partner with that at Emory. I think that that's a great future thing to be able to partner with something like that and looking further into that. I think right now, obviously, we have the association with the dietitian, but I think other referrals out may kind of lead to us making a recommendation. Hey, you might want to follow up, but we don't necessarily have a partnership currently with that.
All right, perfect. So with that, thank you again. There are some additional questions if you wouldn't mind taking a look at the chat box. With that, I'm happy to introduce our next speaker, who's Patrick Nichols at Vanderbilt University Medical Center, and will be presenting on insurance coverage and payer model.
I am Patrick Nichols. I'm a clinical pharmacist at Vanderbilt. I work in the IBD clinic full-time, and I'm going to be talking about pharmacy benefit plan design and the patient experience. There's my disclosures. So our learning objectives, obviously jam-packed for 25 minutes, but I promise we'll touch on all of them. We're going to discuss the rising cost of prescription medications, define the key terms used to describe the differences in plan design, compare traditional accumulator and maximizer plan designs, explain alternative funding plans and pathways, and describe access barriers created by each plan design. And then finally, we'll discuss legislation and other advocacy opportunities. A few ground rules before I start. When I say insurance plan, payer, I'm mostly using those interchangeably. And I know others have talked about this, but we got to admit that specialty medications are very expensive. So just keep that in mind as we talk about these designs. And then in many of the dollar examples and calculations I'll use, and you'll see as we go, I'm making those in a vacuum or silo, so I'm not taking into account other healthcare expenses that the sample patient may incur as they go throughout the year. And I do not differentiate carved in versus carved out RX benefits. Statistics are often obtained from patient advocacy groups and manufacturers, and data also comes from Adam Fine, the Drug Institute, Drug Channel Institute. So obviously they are reported, but there's maybe an agenda behind them. So just wanted to make that known. And then our focus will be mostly on commercially insured patients. So how expensive are medications? Very expensive. So one Stelara brand name 90 milligram syringe is over $30,000. One Skyrizi 360 milligram OBI is over $25,000. One Humira 40 milligram pen is over $4,000. And I mean, even our non-specialty medications, 30 budesonide 9 milligram tablets are almost $2,000. So you can see there's just really, really high dollar alarming numbers. In 2021, specialty medications represented 50% of total drug spending at about $301 billion, and 80% of prescription drug spending is on brand name drugs, but only 20% of the total prescriptions. And as we talked about previous, specialty medication FDA approvals are on the rise. Just in the past 5 years, Upadacitinib, Risankizumab, Mirikizumab, Guselkumab, Ozanimod, Etrasimod, Vedolizumab sub-Q, and Infliximab sub-Q have all been approved and have a pharmacy benefit component to their billing. So who is paying? This is just a screenshot from the U.S. Census Bureau showing that 92% of Americans have health insurance now. So that is an increase from 85% in 2010. Obviously, some of that increase is due to the Affordable Care Act, but even with that, over 50% of insurance are, and that's for the whole country, are employer-based. So still employees, is the take-home point, are still paying. Employers and employees of those employers are paying for the medication. In a survey of health plans, 100% of respondents said they have specific strategies to control specialty drug costs. Some of these strategies may be as simple as a prior authorization or a strict formulary, but the strategies will focus more on the day as plan design and how that affects the patient. So a few key terms and definitions that are used to help go through this process. We all may be familiar with these, but I just wanted to give a definition so that we're all on the same page. Copay is the fee responsible by a covered member for a covered service. Deductible is a fixed amount that a covered member must pay out of pocket before benefits become payable. Coinsurance is the percent of cost a covered member pays after the deductible is met, but before the maximum out of pocket is met. Maximum out of pocket, or MOOP, is the maximum amount a covered member or family is required to pay for healthcare in a calendar or plan year. And then copay support are funds provided by manufacturers to reduce out-of-pocket expense for their specific copay cards. So I think having an idea of these definitions, especially when we're talking to patients about issues they may be going through, I think it's good just to explain all these to them, because we've all heard patients say, well, I've met my deductible, but it's still high. But that's when they get exposed to that coinsurance and MOOP. So we'll talk about that a little bit as we go. So for traditional plan design, obviously these are in quotes. The traditional may not be traditional anymore. At some point, traditional will not be traditional, right? So these are, I feel like, few and far between, and we'll show that. I have a statistic to show that, but these typically have a tiered formulary. So they'll have like generic, brand, specialty, and maybe even additional tiers. And these are the ones where you're more likely to see an even dollar amount copay. So it's like a $10, $35, $100, even $400 maybe for specialty medications. So an even dollar copay. With the benefits of this plan, the benefit to the patient, copay card funds do contribute towards deductible and MOOP, and copay card funds often even pay for a patient's entire annual MOOP. So these are the plans where the copay card patient basically pays nothing. The copay card takes care of their entire deductible and MOOP, and that's for the entire year. Challenges with this plan, with these plans, copay card funds may not cover the deductible, especially with high deductible plans. I know we're seeing this issue more commonly with the adalimumab biosimilars, just because the copay programs are not as robust. And so patients may, the amount on their copay card may fall short of the out-of-pocket. And then this next challenge, employment or insurance change, that really carries over with all the different plan designs, but copay funds can be exhausted, and then you have a new insurance and your deductible and MOOP start over. So you're have diminished funds on your copay card, but a new set of deductible and MOOP to meet. So here's our patient case, and I'll use this case 3 times with the 3 different plans. PN is a 43-year-old patient prescribed a specialty medication with the list cost of $2,000. He has commercial insurance with an annual deductible of $4,000. After his deductible is met, his coinsurance is 40%. His annual MOOP is $8,000. Specialty medication has a copay support program that provides up to $8,000 in funds annually. So you'll see with this traditional plan design, take home really is that the patient pays $0. So the manufacturer, the $8,000 amount that they are willing to pay for the drug is divided through the first 7 months, and then the insurance pays more as the year goes on, and the patient pays $0, and then it does satisfy their maximum out of pocket throughout the year. So by June, they have no out of pocket, and that's what I'm talking about in a vacuum, because that would carry over to potentially other copays as well for other medications they're on. And so as opposed to traditional, when we talk about the opposite of traditional, we would talk about cost shifting programs. So these are copay accumulators and copay maximizers. The copay accumulator plan design. So these are the ones where the copay cards do not contribute to patients' deductible or MOOP. So the funds provided by the manufacturer are redirected to the insurance plan. So the benefit to the patient of this plan is that they do have an initial copay to card assistance that significantly reduces the copay. The challenge is copay card funds may be rapidly exhausted. I personally call this the sinkhole because it comes unexpectedly. Most patients have no clue it's coming, and then all of a sudden they have a surprise high copay. So I call it the sinkhole. But patients are exposed to out-of-pocket costs in hundreds or maybe even thousands of dollars per fill until they meet their deductible and out-of-pocket cost. And it's very, very difficult for patients if they have an employment or insurance change in the middle of the year. Again, they've already exhausted their copay card funds, and they have an insurance change, and then they have to meet a new deductible and new MOOP. So in this case, all the parameters are still the same. So still the same deductible, same cost of the medication, same co-insurance, same $8,000 are being or able to be contributed to the drug from the manufacturer. But as we'll see, this is where the copay surprise comes in. So for the first 4 months, the drug is $2,000 per fill. The manufacturer is paying $2,000, so the insurance is paying $0, the patient's paying $0, but the MOOP is staying $8,000 for all 4 fills. So then when May rolls around, PN gets that refill. He's out of copay funds. He still has $8,000 of MOOP remaining. So then he's expected to pay the $2,000 for the medication, and that would be for 2 times. And so after June, he's met his deductible, which is $4,000, but he's still exposed to that co-insurance. So even in July, he's having to pay $800 per fill through November just to meet that MOOP. And you can see that goes down. So finally, in December, he's met his MOOP. It's max out of pocket for the year, so his copay is $0. And then, of course, it resets in January. So these are the tough ones to manage. Of course, these are the situations where a manufacturer provided payment card is beneficial because the insurance may see those funds as being paid by the patient, and so that starts knocking out some of that MOOP, as opposed to the traditional copay card that just takes off money when the claim is adjudicated. So the maximizer, again, another cost shifting strategy, is designed to maximize the amount of copay card funds available from the manufacturer. So a traditional maximizer plan sets the copay so that the funds are distributed and extracted throughout the year. So if a copay, if they know they have $8,000 to work with from the manufacturer, they'll evenly distribute that throughout the year. They may also front load high copays to ensure the copay card funds are available and utilized. I feel like that's becoming more common, actually. That way, if somebody changes medications, they can still get those funds in the first 2 to 3 fills. And then this strategy combats copay card programs that limit the amount of funds available to plans enrolled in a maximizer. So that's why I think most of them now are going to that front loaded model where they try to use the manufacturer funds early, but not too early, because then if it's too early, then the copay card company realizes they're using it, and then they'll just cut them off. In this design, patients are often required to enroll in an additional third-party program. So we've seen these: Prudent RX, Save on SP, Pillar RX. Those are all third-party programs that kind of micromanage those funds. And then after copay card funds are exhausted, the copay is manually reduced or manipulated to either $0 or the listed minimum copay advertised by the manufacturer. So some will still go down, like if it's a $5 copay card advertised, then they'll just reduce the copay to $5. So in this design, there are still some benefits for the patient. They have a low out-of-pocket cost throughout the year. But the challenge is copay card funds do not contribute to the patient's deductible or MOOP. So while they pay, very little, $0 or $5 maybe, they get no benefit from the copay card towards their maximum out-of-pocket or deductible. There's also conflict between maximizer plan and copay card administrator. So again, those copay card administrators will turn the card off, and then you have to the maximizer has to kick in, and sometimes that requires phone calls from the pharmacy to explain that the copay card was cut off, and that's why the copay is so high. Manufacturers have terms and conditions that limit funds available to patients with maximizer plans. And then patients are often misidentified by the manufacturer as having a maximizer. So I feel like this is another issue. Sometimes they'll just base that on the BIN and PCN of the insurance, and not the group, or not the actual design. And so patients are identified as a maximizer, and they'll cut or limit their funds, and then it impacts their copay. And then of course, again, insurance and employment change, just really difficult to navigate, because the maximizer, if they use all the copay card funds in the first 2 to 3 fills, and then you change insurances or change jobs to get new insurance, you don't have any funds left. And then if you get put in a traditional plan or an accumulator plan after you've been in a maximizer plan, sometimes you get exposed to really high copays. One example, I hope this makes sense, but I did have somebody explain it this way. So say that I have a friend that wants to pay my mortgage for the month. So they go to the bank and they say, "Hey, how much is Patrick's mortgage?" And the bank tells them. So he writes a check for my June mortgage, and the bank accepts it, says my June payment for my mortgage is satisfied. But then in July, when I get my bill, my principal is the same amount, and I call the bank and they say, "Oh, well, since somebody else paid the mortgage for you, we satisfied your payment, but you don't get to count those funds towards your principal." So I thought that was a really good way of describing it. It's not quite that egregious, but it is similar. All right, so in this case, again, third use of the case, I still have the same deductible, same co-insurance, same MOOP, same copay support program. But with this plan design, as you can see, the maximum out of pocket remains the same. So it's $8,000 in January, it's $8,000 in December. Patient pays $0 throughout the year, so that is the benefit. But if the patient were to change jobs after May, so if you see May, the insurance starts paying $2,000 because the manufacturer copay card pays $2,000 per fill here, which is the total cost of the medication. So in May, still no funds left. So if he were to change insurances, he would be exposed to the high copay with the new plan. So what impact do these have on patients? Well, this is a poster by doctors, I guess it's pronounced Motka and Henderson. It shows that plan design definitely impacts the copay and outcomes persistence. So it says findings suggest, analysis indicates accumulator patients experience higher out-of-pocket cost and less medication persistence compared to patients with standard benefit design. These findings suggest that implementation of copay accumulators leads to higher cost and adverse patient outcomes in the commercial insurance space. So I feel like we see this all the time, but it is good to see this visual. And then not only persistence, but drug abandonment and discontinuation. So this is a article that shows that patients in copay accumulators have a 20% higher rate of discontinuation and 12% lower percentage days covered, or PDC. So just another visualization of the negative impacts these can have on a patient's outcomes. So what are the trends with these plans? Obviously, the reporting on this is lacking just because, what somebody calls an accumulator maximizer is not always a that's not a set definition. But estimates show that accumulators and maximizers are almost equally distributed right now, but accumulators have somewhat plateaued due to legislation. I'll get to that on my next slide. And then maximizers continue to be on the rise. So with accumulators, there's quite a bit of legislation and litigation right now around those. This map, it is updated in real time. I submitted this obviously before the symposium, but I think just since then there's been additional states that have added legislation. But it does represent states that have had legislation against copay accumulators. Most legislation mandates, they use the wording that copay assistance must count toward annual deductibles and MOOP. So that's how they word the legislation. Maximizers somehow use exceptions to the laws to deem some specialty medications as non-essential. So that's how they get the workaround. It doesn't make sense to me necessarily, but that's why the wording, because you think if they mandate copay assistance must count towards annual deductibles and MOOP, that would also mean maximizers are not allowed, but somehow maximizers use exceptions to the law to deem most of our medications as non-essential. All right, so the final plan design I'll touch on is the AFP, or alternate funding plan. So this is another cost shifting strategy, typically utilized by self-funded employer plans. So we think about those, especially smaller employers. They're designed to find an alternative means for patients to access specialty medications. So a lot of times they'll just make all specialty medications excluded from the plan. The patient's then required to use a third-party advocate to assist in securing access. And that access either comes from patient assistance programs or they are internationally sourced. If the advocate is successful in enrolling the patient into a PAP, the AFP charges the employer a fee. So that is the devil, in case y'all didn't know. And the AFPs, it's probably a little harsh on my part, but they are very difficult to deal with. Here's a diagram or picture that actually David and I worked on this article together, just kind of explaining the pathway. So the patients, you make the decision to treat you find out the patient's enrolled in a third-party advocate or AFP, and then they may just right away say send the prescription to a non-US pharmacy. That may be the first step. They may try to get the patient approved for PAP. So most PAPs are not allowing AFP patients to enroll now, but that may be the step. And then if the patient doesn't qualify for PAP or denied enrollment due to AFP enrollment, so maybe not qualified due to income, Then the PBM will reconsider coverage and distribution options, so they can move that to a cash pay option domestically or send to a non-US pharmacy. And then if the patient does qualify for patient assistance, then they get enrolled in the free drug program as almost like an uninsured or underinsured patient, and they get the medication from the manufacturer. This was a not an IBD patient, but this exact picture right here did represent what happened to one of our patients here at Vanderbilt, prescribed an oral oncology medication. So they were required to get a passport and get their medication. It was from a European pharmacy, so they had to have a passport. And they did get the medication in the interim from a US-based pharmacy until they could go through all this process, because they did not have a passport at the time of treatment initiation. But I mean, you can see the steps and how frustrating this must be to patients to go through. Just absurd. So pitfalls of AFPs, obviously delayed access to necessary therapies. Our early data from this, and I think this is a multi-site study, so there'll be some data that's released soon, but time to approval is almost 2 months. Again, patients don't always have to wait that long to start medication. Sometimes the plan will have a way to provide it for them in the short term until they have a resolution. But a practical approval is almost 2 months. And that with Vanderbilt, that's compared to like 2 to 5 days for non-AFP. So that's a pretty big gap there. Treatment abandonment due to the process paperwork required, improper utilization of PAP. So it does take money away from uninsured patients that truly need those PAP programs. And most IBD specialty medications that we would deal with, I would say almost all. Now, there were a few of the adalimumab biosimilars that were still allowing AFP patients in, but I think most of them all now have a statement saying they're not allowed. It does discriminate against lower income employees within a company. Not seeing this much now, but when AFPs first came on the scene, I feel like the lower income employees, so if you were like a janitor at a company, they would try to steer you towards the PAP. But if you're the CEO for the company, they would just cover the medication because they knew you wouldn't qualify. So there is a difference in level of care there. And then, of course, lack of certainty if the internationally sourced medication is not counterfeit. So it would be in the back of my mind if I was getting it from a non-US pharmacy. I mean, it's probably okay, but obviously cold chain integrity there is a question too. And then the pharmacies and pharmacists providing the medication and conducting drug utilization reviews are not licensed and likely do not have proper accreditations. So are these legal? I don't know. I mean, I don't know how they are, but nobody seems to have a consensus. We know federal laws are being violated. Personal importation is a gray area. FDA allows for some personal importation. The list there is on the right side. So I don't think specialty medications fall in this category of either say it says which effective treatment may not be available domestically. All of our medications are available domestically. So I don't know how they get around it, but I did think it was funny on this slide. There is an FDA stamp at the bottom. If you see right in the middle to the bottom right, there's an FDA stamp on this process. So I thought that was pretty comical. And then there are some state legislation that is trying to ban AFP. So Tennessee tried to become the first state to ban AFPs this year, actually in March. SB 420 and HB 870. So it passed the House committee but failed in Senate committee. This specific law was coupled with an attempted ban on maximizers. So our employer groups in Tennessee kind of got together and opposed the legislation as a whole because of the maximizer piece, because they wanted to be able to keep the maximizer option as a benefit design. But hopefully in 2026, it's going to come back and it's going to be a standalone bill on AFPs, and it will pass. But as you can see, that good-looking guy there in the blue shirt got to testify in front of the Senate, and so did I. And then what else can we do to help our patients? I mean, this is just in general for all plan designs. Patient education, be able to explain these terms and plan design features, encourage patients to discuss these issues with their human resource managers, stay informed, build relationships with FRMs and other pharma contacts, track common plans in your area that are frequently causing access issues, create a cheat sheet for each medication and summary of copay support options. I thought that may be a good IBD PharmD network project at some point. advocate. So join the Crohn's and Colitis Foundation. I know they're involved in combating some of these plan designs. Find a local patient advocacy group. Contact your state and federal legislators about these issues, and then tell patient stories. I mean, if you have a patient that goes through this process, the ringer I call it. I mean, it's just terrible. All the contacts, can't find somebody to talk to about what's going on. Tell these stories, get them to tell their stories to their legislators. And I think eventually it will change, especially with AFPs, but these are all ways we can help our patients. Those are my references. I appreciate the time, and I've got a couple minutes for questions.
First and foremost, that was a great presentation. I feel like that was a very large topic to really talk about and really just difficult to get in 30 minutes. So that's amazing. One thing that I know that some of the planners and I were talking about, we want to get our fellows, our new nurses, this should be like a mandatory video to watch before starting, just to get the basic understanding. So thank you so much for putting together such a comprehensive but well just tuned out presentation regarding this. There are some questions coming up. Someone asked, how do you explain these maximizer accumulator plans to patients? Do you have recommendations for resources to provide to patients?
Well, I think explaining it with numbers, I think is, unfortunately, it's sometimes you just have to talk about the dollar amount. And so I think explaining it that way is good. And then as far as resources, I think some advocacy groups do have different resources available to explain. I know the oncology one is good, or I guess it's the American Cancer Society. That one's a good one. To be honest, I mean, I should know this, but I don't know if the Crohn's and Colitis Foundation has anything on this, so that could be an opportunity there too. But but using dollar amounts, I think, is probably the best way to just kind of break it down, throughout the year like we did.
Yeah, the one thing I just want to add to that, because I feel like right now, May, June, July, you kind of alluded to it as well. We're starting to get a lot of these messages from patients saying, why did my copay go up? Why am I being asked to pay $2,000-$3,000? So we're kind of in the midst of everything. So the timing is actually perfect. I know something that I do, and I don't know, Patrick, if you agree with this as well, is a lot of times in these situations, we do sometimes recommend patients contact their member services. And in particular, we give them specific questions to ask them to kind of identify what's happening. Because sometimes I think, like you mentioned, we tell them, can you ask, do you have a copay accumulator? They contact the insurance like, no, we don't. But then they describe the plan that's exactly that.
Yeah.
So, it's these questions to try and get to what's happening. So why is my copay high? Do copay cards go towards my deductible or maximum out of pocket? Is there a third party group that's involved that's supposed to help me with copay? Kind of things like that. So that seemed to help a little bit for us to get better plan design for patients.
Yeah, I think that, and then the other part too is, and again, kind of what you said with, there's no set definition necessarily for what somebody calls an accumulator maximizer. I mean, we know, but the plans may not, term it that way. So another way they can do it is call, especially if it's a copay card issue, it may not be a necessary issue, but if there's a copay card involved, most of the manufacturers are doing their own benefits investigation. So they can call and ask, do you think I'm in an accumulator? Do you think I'm in a maximizer? And then again, they're not always correct. And so I think that's another way to encourage them to reach out. I mean, we have contacts obviously with FRMs and other pharma contacts where we can kind of call on their behalf, but sometimes, the patient does just have to call and ask the copay card, like what do you have me in? Like, why am I running out of money so quickly?
Yeah, and we're kind of over time, but there were just another thing that I just want to bring up as well. Something in particular that I think I've started having more discussions with patients is it's kind of a hard discussion to have sometimes, but it's really talking about high deductible plans because I think a lot of times, especially with copay accumulators, kind of things like that, it's related to the high deductible kind of component.
Mm-hmm.
So it's kind of having that discussion of, maybe for the next cycle, consider not getting high deductible, which means a higher premium, but you don't necessarily have to deal with the headache of this. So
Mm-hmm.
that's always sometimes a difficult conversation, but we've been having that.
Yeah, and I think, like 4 or 5 years ago, we would have patients intentionally pick the high deductible plan because I felt like the copay card programs were more robust. I mean, I want to say I think Humira's used to be like 20,000, maybe. I know Stellaris at 20. So patients would intentionally choose the high deductible plan and then take advantage of those copay card funds to satisfy their deductible. And now you really can't do that because most of them are limiting the amount of copay funds. And so if you do that, you're going to be exposed to some type of copay at some point.
Yeah, absolutely. And then the last plug I wanted to make, Ruby actually posted the Crohn's and Colitis Foundation does have a kit or
Thanks,
toolkit,
Ruby.
patient education. So the link is in the chat. Feel free to take a look. It's a really great resource to have. I think really good visuals too. So if this is something that I think you want to have as a dot phrase or for patient messages, things like that, just a really good resource to help share.
Okay, so I'm Jenna Oto. I'm the clinical pharmacist specialist with the University of Colorado, and I'm excited to talk to you about C. diff and IBD today. All right, so I will be talking about C. difficile in the general population, but I'll point out highlights in the IBD population, and I'm going to be breaking it out into 4 different topics: testing, the initial treatment for recurrence, and then prevention as well. And I hope you can walk away from the talk today with a better understanding of how to manage your patients with C. diff and IBD. Let's take a step back and talk about the organism. So you might have known it by the name Clostridium difficile, but in 2016 it underwent a taxonomic change and was assigned to a new genus. And so now the proper term is Clostridioides difficile. It is a gram-positive spore-forming anaerobic rod, and it exists in 2 different states. So one state is the spore form, and one state is the vegetative form. So the spore form is dormant, highly resistant to killing, really easily spread horizontally from person to person by the fecal-oral route. And there's a vegetative form which causes the infection. And it produces the toxin which causes the infection. And what happens is when you develop symptoms, it's dependent on the toxin production, but it's also dependent on the host and their microbiome and their immune function as well. Oh my goodness. Sorry. Okay, so similar to when Shannon was talking earlier about her talk, why are we talking about C. difficile? It is a huge problem. It's the #1 healthcare associated infection, and it causes about 500,000 cases in the US per year, and 30,000 deaths are associated with C. difficile per year. On top of that, there's rising rates of recurrence, and for IBD patients, they are more likely not only to have C. difficile, but also to have recurrence. We know that when patients get C. difficile, it can lead to complications like colectomy, ileus, toxic megacolon as well. So I mentioned C. diff and IBD is really common. And again, these patients are actually 5 times approximately more likely than the general population to develop C. diff. And when that patient is presenting to you, oftentimes their symptoms are different, or their risk factors and symptoms might be different. Sorry, not symptoms, their risk factors might be different than your typical presentation. So we typically think of older patients as well as patients who have just recently had systemic antibiotics. But for the IBD patient, they can develop C. diff without antimicrobial use as well as at younger ages, and can develop this in the community setting more often as well. So let's talk about testing. It can be kind of confusing. There's no single test that is perfect for diagnosing C. diff, and so I wanted to spend some time on this. Who are we testing? It is that patient who's presenting with new onset or worsening symptoms of diarrhea, and the CDC and guidelines decided that that should be defined as greater than or equal to 3 or more, or greater than or equal to 3 unformed stools per 24-hour period. And for a patient with IBD who has a baseline already at that, you can consider it as greater than or equal to more than 3 unformed stools above their baseline. But it's really that IBD patient presenting to you who has an acute flare, and you want to make sure to be testing that patient for C. diff. Just of note, IBD patients tend to present more with bloody diarrhea when they present with C. diff. All right. One of the biggest challenges when patients are presenting with worsening symptoms is differentiating between that IBD flare and that C. difficile infection, particularly because colonization is really common. In one study, patients with IBD had colonization of 8 to 17% versus the non-IBD matched controls of 1 to 3%. So really common, and the reason why experts and guidelines recommend this 2-step testing strategy. So I'll walk through it. The first step is a screening type test. A PCR is generally what's recommended. And what that's testing for is the gene encoding the toxin, but it's not actually testing for the toxin itself. And so that becomes important because you might be picking up on patients who are colonized, but still can isolate that gene encoding the toxin. The good news about that test is it has a high negative predictive value. So if it's negative, you can be pretty certain that that patient does not have C. difficile. But if it's positive, what you want to do is move on to the second step, which is to reflex to a toxin EIA test. So that's toxin enzyme immunoassay, or EIA, which is actually testing for the toxin itself. And before I talk about the results of those 2 tests and how to interpret them, I want to mention your center might have a different test called glutamate dehydrogenase, and you can position it in that step 1 like a screening test, because all C. diff strains will produce glutamate dehydrogenase, or GDH, but it's a screener because toxigenic strains of C. diff and non-toxigenic strains of C. diff will produce that GDH. So you do need another test to help confirm that. So as far as how to interpret this, so the table on the left, I'll point you to there. Again, if the PCR is negative, you can pretty much conclude that the patient does not have C. difficile. If you have a positive PCR and a positive EIA test, CDI is likely, and you can proceed with treatment. Where things become challenging is when the results are discordant and you have a positive PCR and a negative EIA. And you can see the breakout there in the figure. So if you, on the right, if it's negative, you can potentially assume that this patient is colonized with C. diff. There are some other factors involved. Maybe the toxin is not present in high enough levels to be detected. But here's where you really want to use your clinical judgment to decide whether or not you should treat that patient. And then just a note on the bottom left there that we often wonder, should we be retesting these patients to see if they've been cured of C. diff? And it's not recommended by guidelines because you can continue to shed C. diff for weeks even after you become asymptomatic. And so you would pick up on a lot of false positives if you're testing patients after they've been treated. All right, so let's move on. Sorry about the slides. To treatment of the first episode. Because patients might ask you this, I want to spend a minute on probiotics. So the ACG guideline from 2021 does not recommend probiotics. This is largely because of lack of high quality clinical trials, but probiotics have been suggested as used for primary prevention. So when a patient is taking that course of antibiotics, they wonder if they should be taking probiotics along with it to prevent C. difficile. Or if they've had C. difficile, should they be taking probiotics along with another course of antibiotics to prevent another C. diff infection? And the ACG recommends against this, again, because there's a lack of evidence. We know that probiotics are not regulated by the FDA, and so there's little incentive from the manufacturers to conduct high quality clinical trials on these probiotics, and we know there's quality control issues as well. Okay, so there are 2 FDA-approved treatments, antibiotics for IBD, and I've put the 2 different guidelines there. The ACG guideline from 2021 is complementary to the IDSA SHEA 2021 guideline. Essentially, in terms of initial cure rate of the C. diff infection, both are comparable, so they will provide that cure of C. diff, but where they differ is in head-to-head trials, fidaxomicin outperformed vancomycin in reducing the rate of recurrent C. diff infections, and that is why the IDSA gives a conditional recommendation for fidaxomicin treatment over vancomycin, although they do state that vancomycin can be used as an acceptable alternative as well. The ACG guideline standard doses I've listed on the left there, and there is a concept that IBD patients should really be considered as having severe C. difficile, and so metronidazole should really not be used in those cases. In addition, in the ACG guideline, they call out IBD patients specifically, and they say that if you're going to use vancomycin, to try to use a course that's longer than the standard 10-day course, possibly 14 days or longer. This is based off of a single center trial from the University of Chicago talking about or looking at patients who received more than 21 days of vancomycin versus those that received less, and they saw that the patients who received longer courses had lower rates of recurrence. So if you're going to give vancomycin, try to give a longer course if possible. And for those of you who help patients get access to these medications, you likely know that it's a challenging thing to get patients approved for fidaxomicin, as well as getting the cost down, and so sometimes vancomycin is your best bet. What about subsequent episodes of treatment? I mentioned that the rate of recurrence for IBD patients is really high, higher than the general population. And for every successive recurrence that you have, the rate of having another recurrence goes up. So how do we define recurrence? It's that recurrence of symptoms, diarrhea, coming back along with a positive test within 8 weeks of that initial episode of C. diff. However, in reality, a lot of patients will actually develop that C. diff recurrence within days to weeks of having their CDI treated. The main takeaway I want you to get from treating recurrence is to do something different than what was done before. So if the patient had vancomycin, try to use fidaxomicin. If they had fidaxomicin, you could use fidaxomicin, but try to give them an extended or pulsed taper, or you can do vancomycin in tapered and pulsed fashion. The 2021 IDSA guideline says standard dose vanco is acceptable after fidaxomicin, but they do still prefer fidaxomicin for treatment of recurrence as well. And then for second or subsequent recurrences, again, try something different in terms of medication or regimen. But here you really want to think about prevention therapy if you haven't thought about it prior to that. And I'll talk about the ones that are FDA approved. But for IBD patients, you could reasonably consider using prevention therapy sooner than the second recurrence as well. So I put this screenshot up for the audience to take a look, just so you can reference those tapered and pulsed or extended regimens for fidaxomicin that you can pull from the guideline. And before we move on to prevention, I just want to talk about immunosuppression, because a lot of our patients are immunosuppressed. So what do we do about that immunosuppression? The experts essentially recommend that patients should not hold immunosuppression. And this is really problematic in our era anyway, when the half-lives are so long for our immunosuppressive agents. But on top of not holding the immunosuppression, we want to make sure that if the patient has a concomitant IBD underlying flare, that's being treated appropriately. So as we're treating these patients with the Vanco or fidaxomicin, if they're not improving within a few days of that antibiotic treatment, it's time to consider escalation of that immunosuppression. All right, let's talk about prevention. So you may have heard this. There was a monoclonal antibody targeted against toxin B. However, as of January 31st, it is no longer available. Merck discontinued that, and I won't be talking about it further here. There is a strategy as well in terms of preventing recurrence to utilize vancomycin at a low dose, and there's a couple different types of regimens there. So you could either just have the patient on vancomycin 125 milligrams daily long term, and they've listed potential candidates there, although I'll talk about how conventional FMT really is not available. And then you can also opt to give the patients vancomycin while they're receiving systemic antibiotics. So continue it concurrently with the antibiotics at a dose of 125 milligrams daily, and then sustain it for an additional 5 days after the completion of the systemic antibiotics. And this is based on pretty limited data, but knowing that we have a pretty refractory population in the IBD cohort, this could be a strategy you utilize. So FMT, or fecal microbiota transplant, and here I'm talking about conventional FMT. My understanding is it's really no longer available. In 2024, OpenBiome, the largest US fecal distributor, voluntarily stopped distribution. And in talking to some people in the industry, it seems like it's just really not available anymore. And so it makes it a little more difficult to interpret these guidelines that were published in 2024 regarding FMT. They do talk about FMT-based therapies, which are the FDA-approved FMTs that I'll talk about. So I just wanted to call out a couple recommendations. In immunocompetent patients, they suggest the use of FMT-based therapies. These are the FDA-approved ones. But we can really consider our IBD patients as being mildly to moderately immunocompromised. And in that case, there is a decent amount of evidence supporting conventional FMT use in this population, but not enough evidence to really suggest the use yet for the FMT spores or the enema. So I'll go into the two current FDA-approved products. There's one in the pipeline as well. Fecal microbiota live JSLM enema, formerly known as RBX 2660. It is under the trade name Rebiota, and it is donor-derived, so one donor to one dose, so you can track it back. They're rigorously screened, and the samples rigorously tested. So it's a broad consortium of live microbes from human stool. What they did in the PUNCH-CD3 clinical trials was, after standard of care antibiotics, they gave patients in one group Rebiota, and they gave patients in the other group placebo, and saw how they did in terms of rates of recurrence. And they saw that patients who were given Rebiota had lower rates of recurrence at that endpoint of 8 weeks, and then it sustained all the way out for another 6 months. So IBD patients were excluded from that PUNCH-CD3 trial, but they did a subsequent OLS, open label study, in which they did include 74 IBD patients and essentially saw the same thing, that it's effective and safe. So this is FDA approved to prevent the recurrence, and I want to call out prevention, not treatment, of C. diff infection in adults following standard of care antibiotics. And they're going to stop the antibiotics 1 to 3 days prior, and then a healthcare professional will administer that rectal enema that's 150 mLs. So you see some of the supplies there. The patients will either lie on their left side or in the knee chest position, and then the enema gets gets inserted, and using gravity flow, the contents of the solution will flow down, and the patient has to remain in place for 15 minutes afterwards to avoid cramping. The other agent is under the trade name VOWS, so fecal microbiota spores, formerly SER-109. And again, this is donor-derived, one donor to one dose. What they do is they take the donor stool and they actually wash it in ethanol to remove all vegetative bacteria, viruses, fungi, and then they centrifuge it to just have these purified Firmicutes spores, which are thought to be helpful in preventing C. diff from recurring. So in the EcoSpore 3 clinical trials, they looked at patients who had recurrent C. diff, gave them standard of care antibiotics, and then gave one group the VOWST and one group placebo. And again, similar to Rebiota, saw a lower rate of recurrence for those patients who were given VOWST. Unfortunately, they didn't include a lot of IBD patients in the studies, and so they couldn't do any subgroup analyses. There was a subsequent open label study, EcoSpore 4, again, just a small handful of IBD patients were included, and they couldn't do subgroup analysis. So more to come on this medication in the IBD population. So this is also FDA approved to prevent recurrence in adults following antibacterial treatment. They stop it 2 to 4 days prior, and then they take mag citrate the night before. If they have kidney dysfunction, they can use PEG 250 mLs, and then they'll take 4 capsules daily for 3 days. Just a quick mention, again, since you might receive these questions about pregnancy and lactation. So overall, vancomycin is recommended first line because we have ample experience knowing that it's safe, it's minimally systemically absorbed, so it can be used in pregnancy and breastfeeding. Fidaxomicin, also very minimally systemically absorbed, so likely safe, but we have less data for that. And then I'll just end with these pair notes. If you, again, are involved in helping patients get access to these, oftentimes it is what leads to the decision to which agent you're going to use is based on which one you can actually get. So with that, I will end and take questions.
Hi, Jen. Thank you so much for diving into this topic. I think this is important always for our patient population, but particularly now with all the sort of moving pieces and complexities with where we're at right now. So thanks again for tackling this. There are a couple questions, I think, in the chat and from myself too. I'll start with one that's in the chat. Can you discuss University of Colorado's strategy on the limited distribution of VOWST? And I think this is something many of us are interested in.
Yes, so I will say that I wasn't necessarily the one that was involved in getting acquisition to that, but I know our specialty pharmacy team was heavily involved with trying to get access to that, and that really helped to change how many patients we could start, obviously, because then we have oversight into that PA process. We do PAs even if it's sent outside, but I think there's just more oversight when it's in-house. And then we also have clearance to log into their pay sign system, which helps us to sign up for their savings card without having to go through the manufacturer. We have a panel built so that mag citrate is co-prescribed with the VOWST, and so that doesn't get missed. And then our specialty pharmacy pharmacists will often counsel patients as well about the appropriate administration of VOWST, so patients take it correctly. But I think it was a great win for us to get it. I would encourage you to have your specialty pharmacy team and the stakeholders talk about getting access to that, because I think it has changed our ability to treat patients.
Yeah, absolutely. And you mentioned one thing in particular with like the mag citrate, and obviously, I think care in general is easier to coordinate for more like internal affiliated patients, if you will. I guess along with like the other complexities with regards to like timing of these therapies after treatment and whatnot. I guess I'll just ask in maybe more so in particular in patients who can't fill at your internal specialty pharmacy. What have you found works best for providing all of that information? I mean, hopefully those dispensing pharmacies, when they can't fill at your pharmacies, are providing that, like all of that specific counseling. But just from like a patient education standpoint, is it typically verbal? Do you have like, written patient education? How do you ensure that that happens appropriately?
Yeah, that's a great question. I think we don't necessarily have a streamlined, systematic approach for patients who are getting it outside of our own pharmacies, but I know our nurses often utilize the resources that are available on the VOWST website, because there's quite a lot of them that pretty clearly outline how to take it. And so they'll send that often electronically over to the patients and have conversations with them as well. I know that we've also leveraged the manufacturer quite a bit because it can still be costly, especially for our Medicare patients. And so when we send it to them, I think they're very invested in getting these patients, perhaps a little too invested in getting these patients taking it exactly appropriately, because we've gotten a lot of pushback, particularly if the patient already finished their antibiotics before that 2 to 4 day window and they're wanting us to continue to extend it. It's et cetera, just to make sure they're within that window.
Yeah, thanks for answering that. I think you raise a good point too, of like almost in a way not making like good the enemy of perfect in these cases. So thanks. A couple more questions that are in the chat. What is your approach to care for a patient with an IBD flare, considering a change in IBD treatment and then is found to be positive for a C. diff infection? So I think situations that come up often in our patients.
Yes, and I think the concern there is that if you escalate the immunosuppression, that you're potentially worsening that underlying C. diff infection. And it's a valid point, and there's some data that demonstrate that steroids and other biologic medications could be worsening that, but overall the approach is to treat both concurrently. And I think I've heard, as many of you may know, Dr. Jessica Allegretti, who's kind of the expert in the field, talking about how she has no concerns about co-treating both the IBD flare and the C. diff infection, but that's a really good question.
Thanks, Jen. A couple more I think we have time for. Are there any concerns for vancomycin resistance with long-term use?
Yes, so not that I'm aware of in terms of C. difficile resistance, although there's some reports. I think it hasn't really been ironed out yet. I think I did see something in Cleveland where they reported C. diff resistance to vancomycin. But one of the bigger concerns is if you're giving vancomycin long-term, are you inducing resistance to other pathogens like VRE? So that is a potential concern. I mean, you're giving it low dose, but I don't know that there's a ton of evidence yet to give us a solid answer. With the advent of these FDA-approved preventative therapies, there's some thinking that maybe the strategy of giving vancomycin low dose long term isn't really all that great, or giving even the treatment course long term isn't all that great, because we are still disrupting the gut microbiome by doing that. And so, yeah, I don't have a great answer for that. I've heard there really isn't a lot of resistance for Clostridia to vancomycin, but concern for resistance for other pathogens.
Absolutely. Okay, great. Well, thanks, Jen, again so much. Again, this was like a big hot topic right now, so we really appreciate it. And I will hand it off now to our next speakers. I'm excited to introduce Jessica Fan from Vanderbilt University Medical Center and Katie McDaniel from Kaiser Permanente, Georgia. And Jessica, I'll hand it over to you to start.
Hey everyone, thanks for joining today. My name's Jessica Fan. I'm a clinical pharmacist with Vanderbilt Specialty Pharmacy. I work fully embedded in the Vanderbilt IBD clinic. So today, Katie McDaniel and I will be presenting on our innovations together as streamlining referrals and orders, enhancing provider and pharmacy efficiency through smart integration. Here are our disclosures. So our objectives for today include introducing the IBD pre-treatment assessment used at Vanderbilt, illustrate how the assessment is utilized in an IBD clinic to capture desired data, introduce the KPGA IBD Smart Set, illustrate how the Smart Set can improve efficiency and promote standardization of care in the management of IBD patients. Our combined presentation today will focus on ways that our teams were able to utilize technology to streamline our processes, including referral data collection and the management of IBD specialty medication onboarding processes. So both teams have tools that we were able to implement into our EHR to manage and streamline the IBD specialty medication processing from beginning to end. So these tools include both smart phrases and smart sets to assist with data collection and improve provider efficiency. So first, I'll move into specifically looking at the tools that we have implemented at Vanderbilt, which is the IBD pre-treatment smart form, a smart solution for discrete documentation. So our pre-treatment assessment was created out of the identification of a few pain points within our current processes that we were looking for a way to solve. There were a few challenges that we faced, with the first of those being a way to track our referrals. We were interested in a more streamlined process that could easily be tracked and reported on. The referral process prior to the pre-treatment assessment implementation, it wasn't really a process at all. It included multiple ways that our provider team would send over a referral, and then our VSP team started the benefits investigation or the PA process. We never had an official referral documented, and it made it really hard to track the referrals in a standardized way. We also didn't have referral dates documented anywhere. Anyway, we were relying upon chart diving to see when the referral was sent, or we were utilizing the date that our team started the BI task. Kind of in the same realm, the second challenge we hoped to solve was finding a way to collect certain data of interest so we were trying to find a way in the same realm. The second challenge we hoped to solve was finding a way to collect certain data of interest for our ongoing or future outcomes research projects. So there were certain data points that we consistently collected with each project, and we hoped that we could find a way to make that less manual process of chart diving. With each of these, it was really important that the solution we found would provide reports that were easily trackable. So the goal was to create a way for our pharmacist team to document this information as a normal part of our workflow. So with the increased growth in our clinic, we knew that wasn't sustainable to add something new to our processes that would take away from our normal processes or our normal workflow. So the solution that we found was to design and create a tool in the AHR that allows our pharmacists to document in a structured way, which we now call the IBD pre-treatment assessment. So this is an image of what our pre-treatment assessment looks like as we're completing it. So the assessment is created within NoteWriter, and it utilizes a smart phrase to initiate the note. You can see the smart phrase that we use is VSP IBD pre-treatment assessment. We're able to quickly click through and complete the assessment utilizing the initial referral message and the most recent chart notes. We're able to bring the chart notes to the sidebar, which can make filling these out a lot easier than clicking back and forth between the chart notes and the assessment. So this is a larger image of what our pre-treatment assessment looks like as we're completing it. The assessment is created within NoteWriter, and it utilizes a smart phrase to initiate the note. So one of the coolest things about our assessment is that it was entirely built upon what our team needs were at the time. So we knew we wanted to capture a lot of our referral information to support our requests for streamlining the referral processes. We also chose to make some of the assessment pre-filled for easy clicking instead of free text. And then this also made it really easy for us to report. It made that reporting process a lot easier and cleaner. There were a few other data points we added, like specifying if this referral is for an escalated dose, which you can see at the bottom. And then the next slide, this one highlights a few more interesting collection points, like if this request is for dual therapy. And then if it is for dual therapy, we're able to specify which 2 advanced therapies are being used for dual therapy. We also collect the previous tried failed therapies, which that comes in helpful in multiple ways. Our pharmacy technicians who submit our PAs are able to utilize this information to submit the PA without having to chart dive and find previous tried and failed therapies. This is also helpful for our outcomes projects. So we've found that this is one data point that we were consistently collecting, but it was painful chart dive each time. So here you'll see that we also collect if any of the previous advanced therapies were dose escalated. That continues to be an important potential indicator that a patient may need further advanced therapy dose escalation. We also collect non-specialty medications that were tried and failed, which is mostly used during the PA process. And then one unique thing that we collect with this is the SIBDQ dates and scores. This stems from our ongoing efforts to have a standardized patient-reported assessment available if needed for renewal PAs for those patients who may not have been seen within a certain time frame to assess clinical response to a medication at the time of the renewal PA. So one really cool thing that we're currently working on adding, and it really should be live this week, I think, is that our assessment will have the capability to automatically send the SIBDQ questionnaire if we select no to the question asking if the patient has an SIBDQ on file already within the last 30 days. So this is just another way that we're able to remove some of the manual processes of sending a separate portal message containing the questionnaire. And then additionally, we track the infusion history and if there was a previous infusion reaction found. So here you'll see a picture of what the final note looks like in the chart. So during the build of the assessment, you're able to determine if certain fields that you prefer to be hidden from the note. So this is helpful if you're collecting certain data just for internal reporting issues. An example for us is that with the actual referral details, like the method the referral was received and the date, we wanted those hidden. That's not something we wanted in the chart. So this was important for our team, but not necessarily important for the clinical note or for those who were utilizing the note for the PA submission. The final note is then sent to our pharmacy technician team who completes the prior authorization, and it's used for the BI and the PA process. The best part of all of this is that the report can be generated from each field in the assessment, and we found that that's so unbelievably helpful in our outcomes research to be able to pull those reports. Being able to pull the previous tried failed therapies reports for a patient that maybe, for example, had a previous dose escalation with Skyrizi, and then we're able to upload that report directly to the REDCap for a project. It's taken multiple steps out of what could be a really time-consuming process. So as far as uptake of utilizing a pretreatment assessment, the first part would be ensuring user buy-in, as the assessment does have to be manually completed each time. Additionally, the assessment requires an IT build, identifying who would complete an IT build at your location and determining what information they need to complete the task. Fortunately for our team, we have an Epic provider builder on the VSP team who really bridges the gap for taking both clinically, talking both clinically and in the IT realm. So that makes the customization a breeze, and we're able to kind of customize it on the fly. And then, as I already discussed, the assessment is highly customizable. So determining your desired content is an essential step. Getting creative with the information you're able to collect could really help with data collection in the future. The feedback is overall positive within our team. The benefits that we've seen again include a more streamlined PA process that cuts out a lot of the chart diving for our PA team. And also, I can't say enough how much the assessment has relieved a huge burden during data collection in our research projects.
So thanks. I'm Katie McDaniel, Clinical Pharmacy Specialist for GI at Kaiser Permanente, Georgia. And to maybe conclude today, I'll be talking about leveraging an IBD smart set to improve provider efficiency in the management of IBD. So many of you may already be familiar with what a smart set is, but for those that may not, as a refresher, it's a tool within Epic. It can be located a variety of different ways, but usually it is on the ribbon at the top of an open encounter. Sometimes it may also appear on the left-hand side near the storyboard. So when the smart set is selected, there'll be a search field, and then you can enter the relevant smart set that you're looking for. The smart set naming may vary by institution. So at our institution, we just call it IBD smart set. And to my knowledge, unfortunately, there isn't a template within Epic. So this would be, in a good way, customizable based on organization, but it may require a separate build. So today, I just want to show, our example of how we use this at our institution. So when we search for the smart set, this is what it looks like when you're in an open encounter. And just wanted to highlight that there's a variety of sections. So some advantages of using a smart set is that you can include orders for labs as well as medications. You can also include other things such as procedures or diagnoses. So it's very highly customizable. It can include a variety of aspects of care. So for example, the progress notes section, we have a pre-built smart phrase that can be, incorporated into a note. We have about 21 different GI providers at our organization. I do work with all of them. So as Jessica mentioned, there's a lot of chart dive initially, but this standardized smart phrase for the notes does help to streamline documentation, which can be really beneficial for not just, physician to pharmacist management, but also if the patient were to see other providers within the group. So standardization of care. We have a section for diagnosis codes, and this includes the ICD-10 codes for IBD, which includes Crohn's and UC. And then we have a section for endoscopy. Since these patients do periodically require different procedures, we already have those procedure orders pre-built. And with a click of the button and signing the orders, the providers can sign, and then the patient would be able to schedule accordingly. The next section includes biologics and small molecules in order of preference within our institution's formulary and prior authorization criteria. And then we have a section for immunomodulators, as well as the various mesalamine formulations. And then we have additional sections that can address additional patient care needs. So we chose to include supplements, flare orders, additional screenings and referrals, vaccines, and patient education. So as pharmacists, we may be most interested in what does the medication orders look like. So we opted to include each section based on the drug name, but there's a lot of ways that this smart set could be designed. You could choose to design it for ulcerative colitis as a large section with a separate section for Crohn's disease. You could even further break it down to like fistulizing Crohn's disease, small bowel Crohn's disease. You could have sections based on your institution's needs. So at our organization, we decided to just list it based on the medication, since many of these drugs have multiple indications. So you can see here the Entyvio section. There is a section for baseline as well as maintenance labs. And then we have pre-built orders for the infusions and for specialty pharmacy for the subcutaneous maintenance dose. When you choose the baseline lab, this is what appears. So the intention with this build was that we wanted to have as comprehensive as possible orders to minimize provider fatigue and to help promote standardization when they're ordering. So with 2 clicks, essentially, in signing orders, the provider can sign all 20 of these baseline labs. And then there's always the option that the provider can unselect, labs that the patient's already completed or labs that may not be pertinent to the particular patient. So we try to include as comprehensive a list of baseline labs as possible. You'll see CBC, CMP, different serologies for hepatitis A, B, and C, as well as MMR and varicella. We also check for gamma interferon and fecal calprotectin, along with ESR and CRP for many of our patients. It may be appropriate to do HIV screening prior to treatment for some patients, as well as to test for different nutrient deficiencies, such as vitamin D, B12, folate, and iron. So those are the labs that we decided collectively as a GI department. But this is, again, highly customizable. And it can vary from medication to medication. So maybe your institution doesn't feel like all of these labs are necessary for baseline starting of Entyvio, but maybe that these would be appropriate for like baseline prior to starting small molecule. So in addition to the baseline labs, we have separate labs for the maintenance dose, and this can include therapeutic drug monitoring. And then again, the other orders for this section. For immunomodulator medications, we have separate baseline labs as well as maintenance lab panels. And a really amazing thing about Epic is that we can actually customize this based on the gender for the patient whose encounter you are in. So for example, with methotrexate, we would want to check for HCG or do a baseline pregnancy test for our female patients. So we can include this in the baseline labs for female patients, but it won't be selected when methotrexate is ordered in a male patient. Additionally, we can order not just the prescription medications, but there's the option to have pre-built OTC orders as well. So for patients that are on long-term methotrexate use, we also want to supplement folic acid. And this can be ordered even if the patient is using it over the counter. Maybe it doesn't actually need an order for the pharmacy, but it will populate on the patient's med list, and it can be there, to check for drug interactions or as a, just a counseling point moving forward to make sure that patients are not just using that at the beginning of therapy, but long-term as well. So the next couple of sections, these can vary by institution. And when we were designing this, we wanted to think about what clinical scenarios we may encounter, maybe not routinely for these patients. Maybe these are clinical scenarios that come up once or twice in a disease course, maybe even less than annually. And then we also wanted to think about care gaps. So for the clinical scenarios, we identified that some patients may have nutritional deficiencies requiring supplementation periodically, as well as IBD flare orders. So we'll go into a bit more details on the next slide, but in terms of care gaps, so these were additional sections. We wanted to have a section for additional screenings and referrals, along with vaccinations and patient instructions for patient education. So for the IBD flare order, now again, this may vary by institution. We are an ambulatory-based clinic, and we do have multiple locations. So I'm embedded within the clinic. I'm direct patient care facing, but these patients may be like geographically very dispersed. So that, the needs of our institution may vary compared to like a hospital-based facility. So again, the great thing about the Smart Set is it can be customized. If your organization already has workflows to address this, this may not be a section that's relevant. But we identified that sometimes patients were being, maybe their flare management wasn't being optimized. Maybe there were lab tests that were being overlooked and patients were having to come to the lab multiple times. So we created the FLAIR panel that includes labs that we would want to check if the patient is presenting with FLAIR symptoms. This includes additional stool studies and C-diff testing. And again, we can customize this based on gender. So for a male patient, those may be the additional labs that are ordered, but for a female patient, we may also check a pregnancy test, just depending on if there are additional symptoms being reported. We also found that there's a lot of provider fatigue with ordering steroid tapers. So to address that barrier, we have pre-built steroid tapers. Again, we try to minimize this, but during a clinical disease flare, this may be an appropriate intervention. And rather than trying to guess, to reduce error, basically, we wanted to have these pre-built tapers without refills that could be readily ordered for our patients. We also identified that nutrition supplementation may be needed at varying points in a patient's disease course. And that may have to do with disease progression, or it may have to do with the patient's connection to care. So unfortunately, some patients may be in and out of care, not due to choice, but extenuating circumstances. And we know that sometimes that these nutritional deficiencies may not be properly addressed by primary care. And even within GI, sometimes competing priorities take precedence. So rather than, again, relying on the providers to have to remember dosages and things like that, we wanted to have a comprehensive section that could address and have these pre-built orders for nutrition supplementation. So we tried to include some of the most common ones that we were seeing: B12, vitamin D, magnesium, and potassium. And again, we could include some over-the-counter options as well as prescription strength. And we did try to incorporate both oral as well as subcutaneous route options, because we know that, again, depending on the disease activity, there may be poor absorption orally. But ultimately, the goal with both of these sections was to improve the efficiency and ensure that comprehensive care can be provided to our patients. So for the final sections, we were also trying to address care gaps because we know that the more comprehensively we can treat our IBD patients, the better outcomes that they have clinically, and we can, potentially reduce some of the negative quality of life effects. So at our organization, we identified vaccination, smoking cessation as some of the most common care gaps that were being overlooked. So we have sections to address these. And then we also identified the DEXA screening was sometimes being overlooked. And again, this may be something that is not routinely ordered. So we wanted to have that available for the providers for ease of use for ordering. Didn't want them to have to remember or go back to a workflow or an email to try to remember how to order this. And then thinking about comprehensive care, we know that sometimes patients may benefit from referrals to additional specialties, such as nutrition support, dermatology if they're experiencing different adverse drug events or extraintestinal manifestations, as we heard earlier in an earlier presentation. Also referrals to behavioral health, because we know that, a poor management of depression and anxiety has very tangible effects on their IBD symptoms and just the quality of life with their care. And then additional referrals for OBGYN for our patients that are like our female patients of childbearing age. We want them to keep up with their cervical cancer screenings, and particularly if they become pregnant while on immunosuppressive therapy, we want them to be linked or at least referred for additional OBGYN support. And then finally, clinical pharmacy referrals. So I know Jessica mentioned an excellent solution that her organization's identified, which I really loved, by the way, capturing that non-discrete data and turning it into discrete data. So our organization took a slightly different route. We have a very elaborative elaborate collaborative practice agreement between clinical pharmacy and the different physicians within our organization. So I do have a collaborative practice agreement with GI, and so we opted to have a formal referral built because we know that IBD patients, their care is a little more complex than some of the other disease states, managed by other clinical pharmacists. So we did receive organization support to have an IBD nurse navigator as well as the clinical pharmacist role. So this referral is, you can see some of the details of the referral. The provider, it's for GI internal use only. And when the provider selects IBD biologics for GI provider use only, and then completes, signs the referral, it routes to our IBD nurse navigator. She does an initial phone outreach where she helps to address some of the care gaps, such as vaccination and depression screening, among many other things. And then she also schedules the patient with me. So it helps to cut down on some of the back and forth and, with scheduling. It also is a very trackable way that we can track how many referrals are sent for IBD care, which is important, with showing just the return on investment with this service. So one thing to note within the IBD pharmacist referral, there's a smart phrase that's embedded in the comments section, and there's different reasons for referral. So that may be new start on biologic therapy, escalation of therapy, and in some cases, even de-escalation of dose or frequency. So thinking about the IBD SmartSet uptake, initially we had to seek provider buy-in, which it was enthusiastically granted. Next, we coordinated with informatics and IT to build. And full transparency, this was a multi-month build because it was a very extensive, we tried to make it a comprehensive SmartSet. But the feedback has been overwhelmingly positive. The SmartSet benefits the physician group, the PAs and nurse practitioners. I use it extensively, and ultimately the patients benefit because they have more comprehensive care. So thank you so much for your attention today, and I'd love to open it up for any questions.
Katie and Jessica, thanks so much for integrating these kind of related but still nuanced topics. I think this hits like an important discussion in making the whole process as easy as possible for, I think, everyone on the care team with regards to, providing as much support as possible. So thanks again. There's questions for both of you guys, so I'm going to do my best to go back and forth. And Katie, I think you kind of just hit this towards the end of like the feedback's been overwhelmingly positive, but there was a question of what had the uptake been of using these smart sets, and maybe you can speak specifically to, even when change is very positive, change can still be hard for people. And so what did that uptake look like? And kind of speak to like how long that process took, and are pretty much all providers using it now?
Yeah, that's a great question. Actually, I meant to mention this, but future state, we want to have a pharmacy resident project to actually retrospectively look at, what tangible numbers there are with the uptake. So initially it went live last April, and I know as of like 3 months in, like I think it was last July, we pulled some preliminary numbers, and there was, varying utilization depending on provider and provider comfort with, some of the different tools in Epic. So I think there has been different levels of engagement, but, I'm a strong proponent with just re-educating. So as much as I can, when new providers are onboarded, I mention it, I show them how to use it. Initially, when it went live, I also did a brief demonstration during our GI department meeting. So just trying to, keep teaching the old dogs new tricks as much as I can.
That's a great way of putting it. And I think we all feel that often in different situations. Jessica, I'm going to flip back now. And so going back to your new referral tool, do your providers like this as well? I'm sure it makes research easier for them as well. And yeah, I would be curious too, with a new tool that obviously you were very involved in building, has the, reporting that it's able to lead to primarily been pharmacy driven for now, or have providers kind of jumped on that?
Yeah, I think that's a great question. For now, it's just been pharmacy driven. We have several projects that we work on with our providers, and they really rely heavily upon us pulling the data for those. So this just makes that process a lot easier. And so at this time, they're not using it, but I think that they're happy that we have that available if we did decide to pull the referral data.
And this maybe kind of goes along with that too. I know even for myself in particular, one sort of barrier we've run into is the data sometimes is pullable, it's different for like infusion medications, just with regards to how it's ordered versus prescription medications. So that referral tool, does that primarily drive pharmacy benefit medications or infusions as well?
So it's pharmacy benefit. So my team, we only manage self-administered medications. We have an infusion pharmacist team in our IBD clinic. And so they have their own reports that they pull too. So we can merge those together if needed, but this is just the self-administered medications.
Yeah, no, that makes sense. I was just curious. Katie, going back to you, I noticed that Smart Set includes like the IBD progress note and then diagnosis code. So are providers typically using this, or just based on the feedback you've gotten, using this like during office visits, or will they like use the Smart Set as well to like for, I don't know, in an orders only encounter or like between visits?
That's a good question. I don't know for sure. I don't have data as far as like the different encounter types. I have seen some of the providers using the note template. So I do think there's been some buy-in there. And then I just know from personal use when I'm using it, I do use a different note template because again, we were trying to standardize provider and I'm one of one in terms of the pharmacy side. But it's been really helpful to be able to just quickly click, diagnosis, drugs, labs, sign, and close the encounter.
Yes, I would second that. Jessica, going back to you mentioned that like before this referral tool, there was like a lot of inconsistently with how these like requests and referrals were coming in. And so you may not have this specific information, but I'm curious if you do sort of like pre and post, has there been any difference in like determination turnaround time since the new process went live, or was it kind of completely untrackable before? I would have to imagine the turnaround times are better in addition to being like more user friendly for everyone.
Yeah, I don't think it actually would affect the turnaround times. It didn't change any of our processes of when we do the BI and the PA. It's really more just standardizing that process. So I think, or I would guess that the turnaround time is about the same. But like you said, it's so hard to track, and really that's what spurred us creating this, because we had no way to track the referrals before, and they come in so many different ways. So hard to say.
Yeah, no, totally fair. I think there's a couple minutes left for a question maybe for each of you. So one more for you, Jessica, for now. You mentioned that when there's not an SIBDQ, that is sort of in the process, maybe even next week, of sending out an automated MyChart message to get a baseline. When patients will fill that out and send it back, will it kind of live forever in a MyChart message, or will that automatically be pulled into any sort of like flow sheet or anything like that?
Yeah, so it comes back to us as a MyChart response. And so I think there's a way for that to be hidden, and we're still exploring that. In unrelated, we have another project going on where if there was a certain number score drop, that would send an alert to the pharmacist. And so we're still kind of exploring too, because if there is a certain score drop, then those need to be reviewed, and who's reviewing them, and who are we sending them to? So it's a good question. They do live in a separate flow sheet for the patient-reported assessments too.
That's, yeah, super helpful. I'm excited to see, where that goes once that goes live.
Yeah,
and
me too.
Yeah, that is very convenient that that's all just kind of automated. Katie, going back to you, you showed the one specific example initially towards the beginning for Vedolizumab, and I noticed in there, of course, there were like the 2 referrals to the infusion center. I'm thinking that's probably for like the induction doses and maintenance doses. Are the actual IV infusion orders placed, like, I guess, are those automatically like linked to those referrals as well, or are those placed at a later time, or like, what does that process look like?
Yeah,
Infusions seem like a different beast for everyone.
Yeah, I was thinking about that as we built these slides a couple weeks ago. We're actually going to be transitioning to treatment plans within Beacon soon. We have not made that transition yet. So I do imagine we're going to have a future upgrade with the Smart Set. But for now, the process is the infusion is orders are sent over as a referral to the infusion center, which triggers a coordinator to call and schedule. At the same time, we do have infusion pharmacists that bridge the gap between like the ambulatory Epic side and then the Beacon side to actually input it for us manually. But TBD about what's going to happen when those treatment plans come. Because I don't know how that's going to look, but hopefully there will still be a way to place an order to initiate the process within the Smart Set.
Sure. Yep. More to come. Okay, well, I think that's everything we have for now. Thank you so much to you both. And there, I think, are a couple remaining questions in the chat if you guys have any availability to answer those for now. But otherwise, I'll go ahead and hand it back off to Kate for some final announcements.
Thank you so much, Shannon. Okay, I just want to say thank you so much to all of the speakers and to the planning committee members for a truly phenomenal program. For those of you who stuck with us from start to finish, thank you so much for being here. As soon as the program recording becomes available, everyone who registered will receive a link. Anyone who registered to receive CE credit, you will get an email today at 4 p.m. Eastern Time that gives detailed instructions as to how you can obtain that credit. And please be sure to complete our post-program evaluation. Your feedback is truly invaluable to us as it helps us plan for future sessions. If you have any questions, please feel free to email ibdpro@crohnsandcolitisfoundation.org. Thank you so much and have a great weekend.